Go on now.
5, 4, 3, 2, 1. Sir, we are live now.
Thank you. Good evening, all. I welcome you to this fifth Meet the Masters course from Masters5 Orthopedic Center. It's my center here in Bangalore, India. And today we have two masters here with us. We have Mr. Shashi Alluri, who has traveled all the way from Leeds, a consultant bariatric surgeon. We'll have Professor Mehul Acharya, who is one of the 9th surgeons in the world to be awarded a prestigious honorary fellowship by the Indian Orthopedic Association. And we have got a fantastic senior advocate, Dr. Arun Mishra, who is very well known in the medical legal circles in India. And myself will be talking, Dr. Srikanth. So I welcome you. And I think what we'll do is, at the outset, I would like to thank all the faculties who have really spared their valuable time to educate us. I thank Dr. Ashok Sham from Ortho TV and Dr. Neeraj Bijlani for bringing it live across India and Southeast Asia. I thank my friend, Mr. David Penford from Clockwork Medical UK for bringing it live in the UK. And thanks to all the sponsors who are standing shoulder to shoulder with my center in these difficult COVID times. And last but not the least, I thank all the delegates, both offline and online, who have joined us through Ortho TV and Clockwork Medical for sparing their valuable time and being part of this unique, thought-provoking CME stroke webinar. So it's a hybrid meeting. I think how we'll structure today is I'm going to do my first presentation on what's new in orthoplasty in 2023. That will be followed by a video on a new concept, at least new for me, called Knee Expert. And we've got a PhD, Dr. Raj, here, who's going to share a few slides, and we'll have a little discussion around it. And then we'll come back to the main program, which will start in roughly half an hour time from now. Okay. So I'm going to unshare now and share my first presentation. Dr. Maharishi, can you see this? Dr. Raj, can you see this?
Your presentation is not visible right now.
Okay. Can you see what's new in orthoplasty 2023?
Yeah.
You can see. Brilliant. Okay. So good evening, all. I welcome you all to this, what I would say is a very futuristic talk. So I'm sure it'll be fun, and a lot of senior orthoplasty surgeons here and across the country will be quite interested to hear what's going on, because information explosion is happening at a very rapid pace in the world. And this talk is about what's new in orthoplasty in 2023, not now, but next year. And for those who do not know me, I'm Dr. Srikanth Kayan. I'm consultant knee and hip surgeon. These are my qualifications. Particularly proud to have worked in Wrightington Hospital, the birthplace of joint replacement surgery in the world. I was formerly consultant in trauma and joint replacement surgery in the UK. At present, I'm a proprietor and MD of Masters5 Orthopedic Center in Gavipuram, Bangalore, and also consultant cohort of corporate hospitals in South Bangalore. And, I welcome all to my first presentation today. And I trained in UK in all aspects of orthopedics and trauma. Special love and interest in computer-assisted robotic knee hip surgery and patient-specific implants, for which I did a General Medical Council of the UK recognized fellowship at the Plymouth Teaching Hospital. I have specialist interest in hip and knee, sports and revision surgery, for which I did a fellowship in Avon Orthopedic Center, which is famous for Avon Knee in Bristol. Then I did a septic revision fellowship with Prof. Gurka in Endoclinic, Germany, is one of the world authorities. And I do offer quaternary referral service to these challenging patients in India. I did my UG and PG from the prestigious Bangalore Medical College Research Institute. And I'm very glad to have my professors here. I was a National Merit Scholar throughout. I bring experience of more than 15,000 joint replacement surgeries over last 14 to 15 years. And very fortunate and blessed to have worked in 4 out of 5 specialist orthopedic units, which are centers of excellence in the UK. and it's even rare for even the UK trainees. I'm also the India director of the world famous Bristol Hip Orthoplasty course, which we are bringing again on 24th and 25th of November 2022 to all the people in Southeast Asia. My objective is to provide affordable but high quality knee hip replacement and revision services in Bangalore, Karnataka, and India. I had to be grateful to my teachers and trainers. Without them, I would be nothing. So I was from the prestigious teaching institute in Bangalore. It will be a blunder not to acknowledge my teachers and trainers and all of you here who make it possible to produce somebody like me. And many of my teachers are here. I'm very grateful for that. Starting from big ones, we had not last year, but last but 1 year, we had Professor Alistair Hart, nicknamed the Hospital Hip Detective by the BBC. So he was part of this meeting, and it was a pleasure to meet Professor Alistair Hart in 2019, just before the COVID pandemic. He's the chair of the orthopedics at the University College London, which is the largest university in the whole of Europe. And he works in Stanmore Hospital, the largest orthopedic teaching hospital in the whole of UK. And here I'm flanked by Professor Alistair Hart on my right side and Professor John Skinner, who is on my left side, who is the immediate past president of British Orthopedic Association. He just sent best wishes to me, for this talk today. Prof. Hart spoke about 3D printing in orthopedics, and we had an exciting debate on the future of orthopedic surgery with my mentor. Experience relevant to this topic, very grateful to Dr. Jonathan Keenan, who taught me navigated and computer-assisted knee and hip surgery in Plymouth. And I was in fact nicknamed Sri the Knee because of my passion for knee. And in recognition of excellence in navigated knee hip surgery, I was awarded a fellowship there and a certificate in 2011, nearly a decade ago. And this is my second fellowship with Dr. Everett Smith, UK head of European Hip Society, and Everett Smith, UK head of European Hip Society. And this was ever doing the first minimally invasive spare approach in All India Institute of Medical Sciences, Delhi. And this is the inaugural Meet the Masters course at Lee Meridian in Bangalore nearly 5 years ago. Very proud to be surrounded by my professor and HOD at that time, Professor Jai Krishna Reddy. And he has been ably replaced by Professor Ramesh Krishna here now. And also Professor Purushottam is there in this picture. This was at Endo Clinic with Prof. Garka. He's one of the 2 world authorities on single-stage infected revision. So amazing to work with such a great person. This is my knee mentor, Dr. Richard Parkinson. He was the president of British Knee Society 2014 to 16. And when I started my first job with him in 2001 in the UK, my first case with him was a revision knee surgery. I started with revision straight away. So almost 21 years ago. And he was voted the top 10 best knee replacement surgeons and teachers. Very interestingly, both my knee mentor and hip mentor, both of them are avid and crazy cricket fans even now. And my name being similar to Krishnamacharya Shrikant really helped a lot in getting along with them. Also, I trained with Frederick Lord. He's an amazing surgeon from Tours, Paris, very famous for an anterior approach to the hip. And he doesn't need any assistant. Has done more than 12,000 surgeries. This is Frederick Lord in Paris, teaching the AMIS surgery. And if you have a dodgy assistant, then or a fellow, then anterior approach is the best one because you don't need assistants, just scrub nurse and yourself. 40 minutes, the hip is done. Trained also with extensively with revision surgeons. Particularly proud to have worked and sort of met Professor Wayne Proprosky, very famous for the Proprosky classification of acetabular defects, which we still use. I met him in Nottingham. And this is Dr. Lawrence Ahara in Bournemouth. I did a surgery with him where he used 16 augments, which is extremely rare in orthopedics. And there's Jeremy Latham, another revision surgeon. So coming back to the basics of knee, we know that arthritis affects around 20 million people in India, it's around 1 in 5. So around 1 in 4 of them will need some kind of surgical intervention in their lifetime. What has COVID proved in India is that there's a big skill shortage in India. And because of the big skill shortage, or because of the big doctor shortage, there's a big skill shortage. And that means that everybody is forced to do, a hip and knee surgery. And I do use a lot of computers and robotics, and there's a dictum in that garbage in is garbage out. If I feed the computer or the robot wrong information, my outcomes are poor. Similarly, in knee replacement surgery, if the training is not perfect, then the outcomes are not ideal. So, and the basic rule in orthoplasty is that if you fail to prepare for surgery, you prepare to fail during surgery. So what's new, and knee, this I've been knowing for nearly a decade and a half, but knee is a complex three-dimensional hinge. That means not only like a door, it opens and closes, but also rotates. So you can just imagine how complex the joint is. So what are the treatment options? There is an analgesic ladder, which we follow. It's from WHO. Once you are run out of that, you can inject. Injecting corticosteroids has been like eons, more than 100 years probably we've been injecting. And newer ones are the PRP, platelet-rich plasma, and viscosupplementation. I did a RCT in use of viscosupplementation and published in the Journal of Knee Surgery Europe. It's an amazing product to use. And we've got something called as SVF, a new kid in the block. And Dr. Raj is here to talk about it. And there's a video to share. And even I'm keen to learn about it. So these injections can be repeated a few times. The indications for knee replacement surgery, many of you know this. These are the types of knee replacement surgery. So what was new, was a computer-assisted or navigated robotic knee surgery or 3D augmented surgery. There is a debate still going on between whether you need to get the alignment right or the balance right in a knee replacement surgery. And all these modern technologies lead to predictable accuracy, make surgery safe and recordable, and prepares better surgeons of tomorrow because it creates transparency, future learning, and accountability. They all act like a patient-specific implant because we now know that all knees are not the same. So what's new in 2023? The artificial intelligence and machine learning enabled robot, the bot, what we presented in last Meet the Masters course, that is going to be new in 2023. Day surgery in orthoplasty, this is becoming very common, particularly in the West. It is largely COVID-driven. It started with doing a partial knee replacement, and then it's taken on to hip replacement, and now total knees are done as a day case in the UK particularly. And soft tissue algorithm, I think this is going to come, and we're going to talk a lot about it. Probably I'll leave it for the next Meet the Masters, really. AR and VR in orthopedics, augmented reality and virtual reality. This is unbelievable new frontier that we are faced with today. I'll share a few slides and go into some details from my recent training in Germany, and I acknowledge Mr. Landerdale for sharing some of his slides. What is new in 2023? Augmented reality. Augmented reality, also called mixed reality, is an interactive experience of real-world environment where the objects that reside in the real world are enhanced by the computer-generated perceptual information. A combination of real and virtual worlds, real-time interactions, and accurate 3D registration of the virtual and the real objects. What's VR? Virtual reality means you are taken into an artificial make-believe world. Like we go into a dinosaur world, play with dinosaurs. We don't know if they existed, but it's not real. We know that it's not real. Or we go into space, into Alpha Centauri or some star. So AR versus virtual reality. Virtual reality means the user's perception of reality is completely based on virtual information, not real information. Coming to augmented reality, what you see is not always true. There's a very famous quote about opinions, like opinions are like assholes. Everyone has one. So, the people might have good or bad opinion about you. Sometimes you have to take it on the chin and move on because you know best what you are. What is this difference between AR and virtual reality? In AR, the user is provided with additional computer-generated information that enhances his perception of reality. What he thinks is true is enhanced by additional data that he gets really. What are the benefits of this technology in totally replacement? Amazing benefits. I was in ISJR in Pune recently. I think I was the only orthopedic surgeon from Karnataka to be there. And there's an exciting debate going on between Navio, which uses burr to do a knee replacement, versus the Mako, which uses a saw. But when we use saw, we have to use mechanical jigs, and the jigs can move. And the Navio people were saying that, look, that doesn't give accuracy. Navio is more accurate. So traditional knee replacement techniques rely on the use of mechanical jigs which can move. The use of jigs has inherent inaccuracies, significant expense as a result of manufacturing, transport, and sterilization after each use, not ideal for day case surgery, limited storage space and sterilization facilities, and cost. What is the revolution which is going to happen next year and future? The revolution is the use of hologram as an instrument, not just a form of navigation. Holograms eliminate the use of metal jigs. What are the benefits? The benefits are that you get a 3-dimensional cut with no chance of infection. It's amazing. So the potential benefits are you mitigate associated surgical costs without altering familiar surgical techniques, simultaneously improve the accuracy and reproducibility of the bone cuts made by the surgeons, reducing and eliminating the use of metal jigs, saves the cost of producing jigs, sterilizing, and shipping of the instruments. So great saving to the hospital. If any hospital owner is watching, then they will say, we need a surgeon trained in these kinds of technology. Drastically reduce the number of necessary trays, maybe to zero in future, reduce the risk of infection because we are not using additional metalwork, improves the accuracy and reproducibility of the bone cuts in sagittal, coronal, and rotational planes, which is not possible with manual knee replacement. This is how the virtual reality or augmented reality jig looks, and this is the testing how to prevent femoral notching. This is on the tibial side. It looks at the flexion extension up and down, varus valgus, and how do we cut it. It's a win-win-win for the surgeon, patient, and the hospital, and even the implant manufacturer, because it eliminates metal cutting guides. That means you don't have to manufacture, ship them, transport them, and do SSD and sterilize them, etc. It improves accuracy and reproducibility for the surgeon and for the patient. And for the surgical hospital, it's fantastic because sterilization cost is reduced, storage, they don't have to have space, and unlimited availability is there. Okay. What happens in Indian situation is that, when we ask for a size of implant, they say, sir, these are the popular sizes, we don't have it, we have to order it. And it becomes very, very difficult. And all the time, people are adjusting, but not doing accuracy. So, but fortunately, thanks to robot, robot clearly tells you this is the size you have to use. And the implant manufacturer has to give that size. You can't say, adjust kar lo saab, it's not done with robotics. I've been doing robotics in Bangalore since last year, works on the same principles. 1 millimeter accuracy is possible. Bone cuts are done, taking 6 degrees of freedom into account. Less soft tissue cut, so less pain and less blood loss. And all these patients have stopped giving blood transfusion. Early rehabilitation is possible, and early discharge, they're going 1 day before compared to the traditional TKR. And this is my first, robotic knee, that to a CR. And Dr. Kaper, who is the inventor of this robotic, should be very proud of this flat line you see there with those blue and orange boxes, which are 1 millimeter. So that shows that from 0 to 130 degrees range of knee movement, this knee is perfectly balanced. The CR knee. I know PS is very popular in India. It's easy to balance. CR is difficult to balance, but here is a perfect balance. And, this gives some objective data now. So this is the immediate post-op of the patient, who had this particular technology, and 2 hours later, she's able to straight leg raise and bend the knee up to around 90 degrees, which is fantastic, and they are very, very happy. So the future, as they say, is now. So their patient-specific implants, computer-assisted 3D robotics, or augmented reality. Advantages are enhanced accuracy, cost-cutting with virtual AR jigs, reduced bleeding and trace, from 6 to 8 to 2. Less soft tissue cut and less pain, blood loss, and faster rehabilitation and better function. And we can reach the holy grail of knee replacement surgery, which is called, forgotten knee. And we can get a future soft tissue algorithm as well. What else is new in 2023? Back to basics, biomarkers of arthritis, anatomy of quadriceps coxa, role of the operator externus hip surgery. They're all upcoming things. Also biomechanics like uni versus multidirectional movement in the hip, what part of the articular cartilage damage and labrum is damaged. And biomechanics of hip ligaments, pre and post THR. So for this, you need to attend the BHAC 2022 end of November. So what is reverse kinematic alignment? Functional element is knee. This is coming up big. The role of sacral slope, pelvic instance, pelvic tilt, Prof. Acharya will teach us now shortly. Role of the patient positioning, whether we need to use level balance and good OT support, smart sensors, and VR and AR are coming. So I welcome any questions, and proof of pudding, when we get technology right, even a very obese patient like this can get a good knee bend day one. And this is another lady, 2 hours post-op, able to straight leg rise and also up to 90 degrees. My colleagues in Mumbai call it as a dancing knee replacement, make them do garba. But in Bangalore, we achieve the same results without making them dance. So I thank you very much for the patient listening. I seek your support to serve these patients better. And now I request Dr. Raj to share a couple of his slides. I'll stop sharing, and then I'll play a video on this new technology, for me at least, called as a knee expert. Dr. Raj, over to you.
Yes, sir. So I'll be sharing my screen with you. Is my screen is visible to all?
Not yet. Just give some time.
Now you'll be able to see my screen.
1 second. Yeah, surge regenerative cell. Yeah, we can see it now.
Yeah,
Go on.
yeah, that is. Thank you, Dr. Srikanth, for giving us opportunity to participate in your conference. And thank you for delivering from the initial treatment options till what's the future of orthopedics and orthoplasty and all. As Dr. Srikanth has already discussed about treatment options of knee pain and osteoarthritis, as he has told that for treatment option initially, orthopedic surgeons are bound to go for analgesics and steroids, and the chain of pain goes upwards, and at last the patient has to go for replacement surgeries. So what Surge Regenerative Cell Therapeutics is doing, Surge Regenerative Cell Therapeutics is fulfilling that vacuum in between the treatment guideline. So for that, we had brought up and patented technology from Australia that is doing autologous stromal vascular fraction grafting in same surgical setting, utilizing minimum manipulation. And from last 7 years, we have treated more than 1,000 patients in India, and we had found it is very effective and safe in all aspects. And our trial says, and our trial is very much accepted in India, and we had got clearance from DCGI and DGHS in India. And that is very much approved from Indian regulatory. That is the crux, what I am wishing to tell you that, and the video itself will describe entire approaches of Surge Regenerative, what we had brought up. So I request Dr. Srikanth, can you play that video for us?
Okay, shall I play the video?
Yeah, you can. Thank you.
Yeah, if you can stop sharing your screen, then I can go to my video.
Yeah, I'll.
Thank you. So we'll have a brief video about this new technology to me.
So meanwhile, Dr. Srikanth is sharing that screen.
Yeah, 1 second.
That video is having entire experience, clinical experience of our patients. That also you'll be able to see it. And what minimal manipulation steps we are performing this surgery. That surgical steps are also being mentioned in that video. Also, the patient selection criteria, you'll be able to see it. For early young patients having osteoarthritis, we are treating those patients of grade 1 and grade 2, and early grade 3, where deformity is not beyond 10 degrees. And we had got fantastic results in that. And this technology is very much utilized in avian patients also. In avian also, we are having 7 years backup data. In that, we had found out significant improvisation in that, as well as that is visualized in MRI and arthroscopy. So that is our Indian experience of last 7 to 8 years.
Yeah, just 1 second, Dr. Raj. I'll just try to load the video up.
Yeah. So meanwhile, I'd got an opportunity to elaborate regarding technology. So
yes, end of slideshow, click to exit. Is it you or is it me? Have you exited out of the?
Yeah, you have to.
Okay.
I'd already stopped sharing my screen.
Okay, sure. Just give me a sec.
Deteriorating joints affects 1 in 60. 1 in 3,000 That is about 17% of Indians, making the country the second largest.
The screen is not visible. We'll be able to
Yeah.
hear that audio.
Just I'm trying to find out where it
Osteoarthritis or rheumatoid arthritis, age, injury, and lifestyle.
Can you see it now? Dr. Raj, is it visible now?
Now it is visible, sir.
Okay, brilliant.
Deteriorating joints affects 1 in 6 people and 1 in 3 families. That is about 17% of Indians, making the country the second largest knee pain sufferer in the world. That is a lot of pain. Most of this is caused by arthritis, osteoarthritis, or rheumatoid arthritis. Age, injury, and lifestyle also play their parts. Osteoarthritis creeps in slowly, advancing from barely noticeable and normal to mild irritating, to limiting moderate, and finally unbearable severe. Patients usually discover their problem through X-ray or MRI, and then starts the cycle of exercises, painkillers, steroids, and finally surgery. However, the science is all set to change this for good. Advances in regenerative treatments have now yielded proven results. Regenerative procedures not only improve symptoms, but cure diseases as well. What was once thought to be irreversible degeneration is now being regenerated. Scar therapy is an innovative surgical procedure which is simple and effective, showing around 85% success rate in terms of quality of life and activity of daily living. It is useful for grade 1, grade 2, and grade 3. It can also be used for grade 4, where deformity is less than 15 degrees. Scar therapy is a special case of already practiced autonomous grafting. This patented technology removes adipocytes and the collagen that binds adipose tissue together. These cells obtained from the patient's bodies and grafted back into the joints where they have been tissue regeneration. This reverses the degeneration process. The results are promising in rheumatoid arthritis and avascular necrosis of the hip. Such therapy is an innovative surgical procedure done in a single sitting and a minimally invasive treatment with no known side effects. It does not use any animal products or cultural tissues. The patients walk home the very next day. No open surgeries, no replacements, no repeat surgeries in a few years. But joint pains, this is the ultimate cure.
That is an unbelievable, amazing presentation. So amazing video. Thank you very much, Dr. Raj, for having shared that with me.
Thank you, sir.
I think what I'll do is, anyone has got questions about SPF? Anybody welcome to ask? If not, I will ask Dr. Raj a few questions. Dr. Raj, I want to know what is the difference between SVF and stem cells?
What SVF is basically a heterogeneous combination of cells. And the results are dependent on that heterogeneous combination, wherein stem cell therapy results are dependent only on one cell. For example, extracellular matrix is going to play a vital role as scaffold in cartilage regeneration and pain relief. So, though in stem cell therapy, generally enzymes and animal products are utilized, what we are not utilizing by doing separation by mechanical means. So we are getting extracellular matrix, M2 macrophages, EPCs, parasites, MSCs. So that's why we are getting very good results as compared to stem cell therapies.
Brilliant. Okay.
And this is done in the same surgical setting. No enzymes, no chemical, no cell culture is utilized. And we are getting cell viability, utilizing our technology of more than 85%. And cell count comes in millions and billions.
And do we have any like RCT analysis of SVF in the last 5 years? I know this technology has been there for some time. So do we have any of those RCTs, or what we call as a meta-analysis, which is level 1 evidence, what we call in medicine?
Yeah, we are having level 1, level 2 evidences that are very much published in peer-reviewed PubMed index journals. And there are RCTs and double-blind trial done along with hyaluronic acid and SVF alone, PRP and SVF, and different doses of SVF also. There are certain trials has been done, and that is being found out that SVF alone has given very fantastic results, and they are having proven efficacy and safety. And safety is also being studied in heterogeneity at global level. So it is claimable that SVF grafting is effective and safe in all aspects.
Thank you, Raj. Thank you, Dr. Raj. Thank you so much for your time and enlightening us about this new technology. And now we will start the official part of the
So one more thing I'm wishing to add into it.
Yeah,
that
please.
Not only in osteoarthritis, in AVN also we had got fantastic results. And we had done many patients of AVN, and we are having follow-up for more than 7 years. So you're talking about
the AVN of the hip, or like the song of the knee?
AVN of the hip. AVN of the hip, we had got fantastic results, and we are having long-term MRI and orthoscopic evidences for that too also.
What I like is, the standardization of the product. The problem with both stem cells and the PRP is that nobody knows what is the dose we are putting. Every company has got their own dose, and we are like hundreds of different things being tested, and somebody says that is effective, this is effective, and because of the lack of standardization, it's got a very bad reputation in both the medical circles and the public. But at least once you standardize your product, like that you're giving 500 milligrams of plasma, how it works, and I think that's a very improvement compared to.
Sir, you had raised very correct point. With standard and entire isolation process that is very much standardized, and we utilize flow cell cytometry, that is called as considered as the gold standard in cell count and viability assessment. So entire cell grafting we'll do by utilizing flow cell cytometer, and assessed quantity of cells is only going to get grafted back to the patient. So entire standardization has been done from the lipoaspiration till the cell grafting.
Okay. Brilliant. Thank you so much. So I think now we will start the official part of the program. This is the program for today, and we had we have 2 talks already done now. And now it is a welcome introduction of the faculties for today and guests of honor. And the first talk will be taking the complexity of the complex primary joint replacement with the help of bariatric surgeon in the morbidly obese with metabolic syndrome, what every orthopedic surgeon should know. And I think a lot of orthopedic surgeons across the country are waiting for this talk. And we have Mr. Shashi Alluri here, consultant bariatric surgeon from Doncaster Hospital NHS Foundation Trust. He's a senior lecturer at Sheffield University. He's a tutor for Royal College of Surgeons of England. He's a MD Cancer Biology from the Leeds University. And I really welcome him to Bangalore and to India. And this will be followed by a brief video on Bristol Orthoplasty course 2022, what's happening. And since COVID, I started this creative corner just to look at life from a different angle. And then we'll have Professor Acharya from Bristol. He'll be talking about amazing concept in hip surgery, completely futuristic. And you'll see that it's creativity in action. And then we have he'll be talking about the hottest topic in the hip joint surgery in 2023, that is decoding the complex spine-pelvic-hip mystery during the total hip replacement. Then we'll have a brief question and answer. This will be followed by a very famous advocate of India, a senior Supreme Court advocate, Dr. Arun. He's going to join us live from Mumbai around 8:30, 8:45. And he's going to tell us about the ideal Doctor-Pharma implant company relationship in India in the light of the new NFC guidelines 2022 and how to keep the doctor out of trouble. And I think this is a very, very topical and hot topic in India right now. And we'll welcome him at that time. And there'll be felicitation of the guests of honor. We have Professor Ramesh Krishna here, HOD of Orthopedics from Bangalore Medical College and Victoria Hospital. He's a medical superintendent. And we've got Mr. Zulfi Kader, who's the younger brother of the Honorable ex-Health Minister of the Karnataka state and also 6 to 7 time MLA. And then I'll introduce Professor Ramesh Krishna to you, and there'll be a brief talk from Professor Ramesh Krishna, and this will be followed by the last but not the least talk called as Get It Right First Time, Grift in Complex Knee and Hip Surgeries in India. So then we will close. So I would like to introduce Mr. Shashi Alluri, who has come all the way from Leeds here to educate us, and he's a consultant bariatric surgeon at Doncaster Hospital NHS Foundation Trust. First of all, I would like to thank him for coming all the way from UK. Thank you, Shashi, for being here with us. He's a consultant laparoscopic, upper GI and bariatric surgeon. We have a fantastic multitude of delegates here, including anesthetists. A lot of questions coming from their side. And he's an honorary senior lecturer at the University of Sheffield. He's a surgical tutor for the Royal College of Surgeons, England, and is a plaque examiner. If anybody wants to UK, this is the understand the nitty-gritty of how you will be tested. Two of my fellows are due to join, so let's see if they come, they can interact with him. He trained in 3 countries, India, UK, and Australia. He has done MD in cancer biology in Leeds University, so we can learn a lot about cancers from him. He's a visiting fellow. He was a visiting fellow in bariatrics in upper GI in London, Brugge, Melbourne, and Brisbane. His interest lies in reflux and bariatric surgery and general surgery. He's going to enlighten us on taking the complexity of the complex primary joint replacement surgery in the morbidly obese with metabolic syndrome. So Shashi, I welcome you, and I'll just stop sharing this slide, and then I will put your slide up. So let's give him a hand of applause. Yes, it's here.
Thank you very much for the warm invitation and the generous introduction, Dr. Srikanth. I'm truly honored to be here. I'm a upper GI and bariatric surgeon in the north of England, and it's my real honor to be here talking to this august audience. So sorry, I couldn't really get my slideshow working on this computer, so I've had to convert this to PDF. So I do apologize for that. So it's a long heading, but the important thing for us to focus would be on the morbidly obese patients with metabolic syndrome. And I get a lot of referrals from orthopedic surgeons in my local hospital and from the region asking for weight loss surgery on these patients who are morbidly obese, saying, can you do a weight loss operation, let them lose weight, they can come back and then we can do a knee or a hip operation. So I looked up data a little while ago, and when Dr. Srikanth asked me to talk on this, I was initially quite excited. but I'm thinking maybe I'm shooting myself in the foot. So we'll see what you think once we finish this presentation. So, I mean, how many of you do hip and knee surgery here or orthopedic surgery? Anesthesia. Okay. Yeah, we got some anesthetists as well. So I've got no disclosures for this talk. So obviously we want our surgeries to last a lifetime. You know, you want to do a hip and knee replacement or whatever orthopedic surgery, and you want long-term results. Unlike the British politics where electors could sometimes outlive the prime minister. So you want your operations to last long-term. This is the typical bariatric patient. You got the smiling patient, we call them the smiling assassin. You know, they smile at you, they look like a normal patient, but obese. But the problem is they have a lot of underlying health issues, and that's both physical and mental, psychological. They have emotional problems. And it's very important sometimes to get to the bottom of that, really. So it's not just about weight loss, it's not about your operation. It's the underlying psychological issues that can sometimes play a big role in these patients in terms of their management. So why is obesity important? You know, you've got the diabetes, which affects your operations directly, cardiovascular problems, heart and lung problems, metabolic problems, obstructive sleep apnea, most of which is undiagnosed before surgery, osteoarthritis and fractures from your point of view. If you look at the definition of the bariatric patient, you know, what's interesting is that the Indian criteria is actually quite stringent. And that's because the Indian patient for the same age, sex, and the BMI has a lot more body fat than the average Caucasian or Western patient. So if you look at this slide, you know, for an average Caucasian patient, anything less than a BMI of 25 is healthy weight, whereas for an Indian patient, it's actually less than 23. And if your BMI is more than 27.5, and if you're Indian, then you're class 1 obese, and that would qualify a lot of us for obesity surgery, actually in India, especially if you're diabetic. Certainly from where I come from, it's not unusual to see a lot of patients who are BMI 40 plus. We call them the morbidly obese or the severe obese, and 50 plus is super obese. In fact, in my unit, the average BMI for operations is about 52 or 53. So we see a lot of super obesity in my practice. So the Indian context is important because you will see a lot of patients with BMI 30, 35, and it's important to remember that these are actually officially obese when it comes to the Indian measurements. So the obesity problem is a genuine problem in India. The prevalence of obesity is up to 25 to 30%. It's actually increasing, and most of this is central. A third of patients would have central obesity, more common in women compared to men. So that gives us a large proportion of patients with obesity. This is based on the ICMR data from nearly 7 years ago, so the numbers are probably bigger now. If you look at obesity in orthopedic surgery, I didn't want to bore you with too many papers, but you look at the data, it leads to longer operative time. There is higher cost involved. The length of stay is longer. There is higher risk of complications, higher risk of implant failure, and a higher risk of prosthetic joint infections. I mean, it'll be interesting to see how this data pans out in the robotic era, you know, where you can get patients home earlier. So maybe there is a case for robotic surgery in the obese patients. So that's something that time will tell. If you look at the American Academy of Orthopedic Surgeons, they've come out with a position statement. This is easily available on Google. If you just Google position statement, it will come out. But it's interesting to note that they recommend caution in patients who have obesity with an underlying health issue related to obesity. So we're talking about metabolic problems like diabetes, for example, sleep apnea, liver problems. So if you have any of those conditions, then there is a risk of increased complications in both the pre and the post-operative period. And therefore, it's important that these patients are looked after properly. But in the absence of these conditions, maybe you can carry on with surgery as normal, but we'll look at that in more detail. So it affects pretty much most operations. You know, you might be an upper limb surgeon, you might think, okay, it doesn't affect me as much, maybe not. But it does affect your operations, and that includes shoulder, hand surgery, spine surgery, obviously hip and knee and foot and ankle, very, very obvious. It also affects trauma. Obviously, if a patient comes in with trauma, there isn't much you can do about weight loss, but I think it's important you talk about patients in the appropriate context, and it's important that you counsel them accordingly. So I'm sorry, again, with the PDF, we'll have to just go with these slides. But if you look at the obese patients and the issues with joint arthroplasty, there is a nearly threefold increase in risk of revisions if you operate on patients with a BMI of more than 35, as opposed to patients with a BMI of less than 30. So in this paper, the authors showed that the risk of revision was about 8% with BMI more than 35, and it's less than 3% in patients with a BMI of less than 30. If you look at this was a large study which looked at patients with osteoarthritis having hip arthroplasty. There was increased risk of morbidity and perioperative complications in the morbidly obese patients. Similar issues with spine surgery, higher risk of immediate post-operative complications. But it's interesting that the results are similar in terms of outcomes in the long term. So obese patients benefit from surgery as well. It's just the initial post-operative period when the risk of complications is higher. Again, similar data, increased risk of significant post-operative complications when you operate on obese patients in the context of spine surgery. Upper limb surgery, again, patients are less prone to post-operative complications as opposed to other parts of the body, but again, the risk of complications is higher. And that includes, arthroscopy, for example, for rotator cuff tears. Amongst all of the factors, one of the important things for these patients is the risk of complications associated with diabetes. So what you have to remember is that a lot of these obese patients will have diabetes as part of their metabolic complication. So if you operate on these patients with weight loss surgery or by whatever means, if they lose weight, sometimes they lose the diabetes, and that could have a direct implication on the results from your operation. So that's important for you to remember, and this is a very good paper along those lines. If you look at the outcomes from bariatric surgery, the results are mixed. The reason for that is a lot of these papers include patients with obesity only, and they include patients with obesity and metabolic complications from the obesity. But overall, the results would show that if you have weight loss surgery or if you lose weight by whatever means before your hip or knee or ankle surgery, then the results are better in terms of lower risk of reoperation, lower risk of revisional surgery in the future, and a lower risk of complications in the immediate post-op period. This paper looks at the operative time and the length of stay, which were significantly lower in patients who had bariatric surgery before elective total joint arthroplasty. This paper compared, again, complications, length of stay, operative time, and again, there was a significant difference in the two groups. This is a meta-analysis, and you can see that there is a significant difference between the two groups, which compared bariatric surgery before or not having bariatric surgery in morbidly obese patients. So similar theme with knee arthroplasty. And again, similar theme in this study from New York. So if you had bariatric surgery prior to total joint arthroplasty, it reduces your risk of complications. Again, it's the same theme really. Same thing again with this paper. So you can see that the theme is similar. They all reduce your risk of complications in the early post-operative period, although in the long run, the results are probably similar. Now, one of the important reasons why I looked at literature a few years ago was because I was getting a lot of referrals from my knee surgeons asking for patients to have weight loss surgery before knee joint surgery. There is an interesting article which came out last year, and I would ask you to look into this if you're a knee surgeon. They looked at obesity and revision surgery in a large cohort of patients, nearly 500,000, through the National Joint Registry in the UK. And what they found was that patients with high BMI were more likely to undergo revision surgery within the 10 years after surgery. But interestingly, the rate of revision was less than 5%, which I understand is the benchmark for you guys. So although for overweight patients, the risk of revision was higher, it was still less than 5% if you're obese or if you're not obese. So what the National Institute of Health Research is recommending in the UK, based on this paper, is that do not turn down patients due to high BMI for a total knee replacement. So if you have patients with a BMI 45 without other comorbidities like diabetes, for example, you could certainly do an operation straight away. But if you've got a patient with a BMI of 45, diabetic, young patient, and you think he'll benefit from weight loss surgery, yes, that's fine. But if the patient is not fit for weight loss surgery, I think you could make the case for surgery firsthand. And I'd certainly ask you to look at this paper. If you go back to the American Academy of Orthopedic Surgeons and look at their guidelines, I mean, again, they are saying, obviously be cautious. The patients need to discuss with their physicians about the impact of their weight on the potential complications in the future. They need to look at the tools available to them about weight loss surgery. If delaying surgery is in the patient's best interest, that is certainly an option because that could improve outcome. But again, this has to be balanced with the risk of patients' quality of life. Weight loss surgery comes with a price. Weight loss surgery will take time. They will lose 1 or 2 years before they come back to ideal weight for you. And are they able to manage with the pain in that time? So you need to look into all those things. And obviously, it's a multidisciplinary team approach. This probably doesn't apply in the Indian context, but there are a number of studies which have looked at the cost effectiveness of bariatric surgery and the quality of life. And there is no doubt that there is a significant impact on cost effectiveness. Bariatric surgery and knee surgery, for example, in this study was cost effective and it improves the patient's quality of life. So if you adjust for quality adjusted life years, there is a significant improvement in these patients, nearly $14,000 as per this paper. There are a number of weight loss strategies which you could consider. Diet and dietitian works for some patients, but when you have patients with a BMI 45, 50, 55, I don't think this really works. There are pharmacological options, again, doesn't work for the super obese or the severe obese. Psychology is an integral part of management for these patients. Exercise program works, but a number of papers, research, data shows that bariatric surgery is the only modality that offers sustained and predictable weight loss in the long term. When it comes to bariatric surgery options, I've kept it brief. I know it's an orthopedic audience, but we have an endoscopic balloon placement option, which will give you 20% excess weight loss. Patients can have this with sedation. You take the balloon out in 6 months. So it's like a temporizing measure. So certainly if your patients would benefit from that little weight loss, that's an option. Gastric band needs a GA, but you could achieve 40 to 50% excess weight loss. And there is the option of the gastric sleeve and the gastric bypass, which applies for most of our patients with high BMIs. But you would look at about 2 years before you get that kind of weight loss. So if your patient can wait and can benefit from that weight loss, then that's a discussion you need to have with the patient. So I think what we need is a tailored approach. It has to be patient-centric. Every patient is unique. You have to match that with the patient's comorbidities, patient's expectations, patient's quality of life. What is it they're looking for? Patient's age is very important. Do you want to do an operation in a 40-year-old, who could have a revision in a few years' time? Obviously, if it's an 80-year-old patient, the discussion will be different. You need a close working relationship with the bariatric team. And ideally, you need to have some kind of society guidelines that cater to Indian patients. Dr. Srikanth might want to take the lead on this, Professor Krishna as well. But I think you need some local guidelines based on the Indian population in terms of weight and obesity, because it is a growing problem and it will only get worse in the future. So I think in summary, the data supports that there is increased risk of complications in the obese patients undergoing orthopedic surgery. This is particularly the case with metabolic complications. So if your patient is diabetic, has OSA, has hypertension, just be cautious. The results are still acceptable. Therefore, surgery and timing should be tailored to each individual patient circumstance. I think counseling is very important. I know we're going to listen to an advocate later about medical legal aspects, but I think counseling is important. Documentation is key. You need to have that documentation saying like you're obese, your risks are higher. Can you wait? Can you have weight loss surgery? Can you have weight loss by other means? You want to come back to me once you've lost the weight, or maybe build in a package where you work with your bariatric team, they go for weight loss surgery, then they come back to you in 2 years' time. Or if the patient is keen to get on with surgery, document that, make sure they understand that their risk of complications is higher, but still maybe acceptable. So weight loss should be considered when feasible, but I don't think you should refuse patients for surgery, especially if they don't have the comorbidities like we've discussed. Thank you very much. I'm happy to take any questions, really.
All surgeons listening online, so please repeat the questions so that they can also be addressed.
Sure. Yeah. Yeah.
Once if the patient starts with less mobility post surgery.
Less mobility.
Less mobility post surgery.
Yeah.
Can we go on with bariatric surgery after the start of this? I think we come across such type of patients with start replacement.
Yeah. No, absolutely. So the question is, should we do bariatric surgery before, or is there data to show that bariatric surgery after procedure is beneficial? So yes, absolutely. That's a very good question, and I've looked at that also. If you look at the data, the majority of complications happen in the immediate post-op period. Actually, the long-term complications are not bad. So if you do any kind of orthopedic joint arthroplasty, I wouldn't recommend bariatric surgery in immediate post-op period anyway. But if you do it 6 months down the line, I think the benefit of the immediate post-op complications is lost. So yes, if you have a patient who doesn't mobilize as well and you think they will benefit from weight loss as well, yes, that's an option. But I think if you want to consider bariatric surgery, my understanding and my experience from looking at the data is that it's better to do it before, get the patient to an ideal weight, and then do the operation. But equally, the data clearly shows that if your patient doesn't have the metabolic complications, the results in the long term may not be bad actually. But you need the motivated patient. That's where I was talking about psychology and counseling, because a lot of these patients have emotional problems, they're emotional eaters, they've got psychological problems. So the lack in mobility may be an element of weight, but could be down to psychology as well. A good psychologist is what you need as well in the team for these patients.
I do not feel in Indian context that doing bariatric surgery will cause a lot of metabolic issues which we are not able to manage.
Yeah.
The best thing is not to do it. So what would you say to such critics?
Okay, so the question is, there's a lot of misconceptions in India that bariatric surgery leads to metabolic complications. So we need a good follow-up plan for bariatrics. In the NHS, we follow up these patients 3 monthly to 6 monthly for the first 2 years. But after that, we discharge them back to the GP, the general practitioner. These patients are followed up with blood tests once a year, and they need regular nutritional supplements, so daily supplements. So as long as they take the supplements and you check their bloods once a year, we should be able to manage these patients in the community quite easily. Yes, there is the risk of nutritional deficiencies and mineral deficiencies in the long term, but the risk is very low and is unfound really. So I think if you have a patient who will benefit from the operation, then I think you should go for it.
The recovery post-op is better. After that makes sense.
Yeah.
Especially diabetics and obesity.
Yes. Yes.
The moment that is removed,
Yeah.
the sugar settle down.
Yeah.
First of healing happens faster.
Yes.
And they can be mobilized early also.
Absolutely.
Coming to this bariatric surgery, how will you decide, going by the patient's profile, like which type of see, 4 things you mentioned?
Yes.
One is the balloon,
Yes.
then you have the banding one, the growing one, gastrectomy. Okay,
Yeah.
so how will you decide which patient needs what type of surgery?
Yeah, so the question is, which patient will need what kind of surgery? How do you decide on that? Actually, that's easy for us, actually. So if you have patients with a BMI of less than 35, then a balloon or a gastric band is a reasonable option. The only problem with the gastric bands is that if you look at the French registry data recently, 70% of gastric bands are taken out because of complications at 7 to 8 years. So it is good for the first 5-6 years, but then the bands come out because of complications. So it's a good temporizing measure. So I've not done a gastric band now for 5 years because of the risk of complications. I take bands out, but I don't put them anymore. We don't do that in my unit or in the majority of the UK now. So balloon is an option, but if patients are BMI 35 plus, sleeve is a good option. But if they go beyond 45, 50, then a gastric bypass is probably the best option.
How long you can keep it?
6 months.
6.
3 to 6 months. Typically 3 to 6 months.
And banding?
Gastric band, you can keep them for life.
1 life.
Yeah, so gastric band is designed to be a procedure for life, but we find that because of the nature of the band, it tends to slip and patients have complications of gastric band slippage, which is the commonest problem we see.
So the weight reduction with banding,
Yeah.
Continues throughout or stabilizes at a certain?
Again, good question. I mean, most bariatric procedures, I mean, apart from the balloon, will lead to maximum weight loss within the first 2 years. After 2 years, the patient's weight usually plateaus. There is a risk of weight gain if the patients are not careful. So a bariatric dietitian in the team is very, very important because patients can fall into bad habits very quickly. You know, they can learn the tricks around their gastric band or their sleeve. You know, the nature of the gastric sleeve bypass band is such that, you know, the human body will compensate. The stomach will distend, the capacity will increase, patients will find that they can eat more. We have patients who liquidize their foods. You know, you could have high calorie chocolate milkshakes, which will easily go down any balloon, any sleeve, any bypass, and you can easily put on weight back again. So therefore, the psychologist and the dietitian are very, very important members in the team. In fact, 70% of my patients will go to a bariatric psychologist before the operation for the same reason. Yeah, so orlistat works, but again, the risk of complications is higher. In the UK, it's prescribed for BMIs less than 30. So if you're overweight, which is 25 to 30 BMI, the pharmacist can give this without a doctor prescription. But patients have a lot of diarrhea, which is the main side effect that they have. And the weight loss that they get with this is called a yo-yo diet, yo-yo weight loss. They lose weight with the orlistat. Once they stop the orlistat, the weight comes back again. So it's like a yo-yo weight.
Come across morbidly obese patients, Indian senior young people.
Yeah.
Most of them advised, have you advised rather to get a bariatric surgery done? Any morbidly obese patient coming to you, have you advised them bariatric surgery? Post bariatric surgery, have you gone ahead and done?
Yeah, thanks, sir. Thanks for that question. I think the answer is yes. And, basically, you know, I had a lady who was morbidly obese, and I asked you know, my surgical colleague to do the bariatric, and she did lose considerable amount of weight. Really, I think she was 110, 120, like that. And when I operated on her, she was around 85, 90, and I think the knee replacement went quite well actually. So that was quite good. And I've done in revision situation, I've done, but they can't, you know, they're so bad and they don't have a joint itself. They can't even walk. So asking them to go and get a bariatric done is quite challenging in them. So like Dr. Shashi mentioned, I get on with it and do the job really.
Also,
Absolutely. Obese are also very osteoporotic, and you need to be extremely careful. And, you know, I take a lot of precautions, and, you know, I don't bash in the implants. I can push in osteoporotic bones, and they do equally well. And one point I really would like to appreciate what Mr. Shashi mentioned is that, you know, in my UK practice, I remember my last patient I did during my fellowship. My boss was away in Europe and I was alone, and I had a lady who was a BMI of 40, and it was surprised. I didn't know that. I just came to know 2 days before. No backup really, and yes. Anyway, I was finishing fellowship, and literally my elbow got lost in the patient's body, and I was wondering what am I doing here. And always you find that in these morbidly obese patients, the bones are so small. My boss used to say, little lady coming out of a big something. So always the bones are so small, and I used a size 2 or 3 kind of implant in that knee. But if you ask me, did I enjoy the surgery? No. But did I learn a lot? Definitely. So it's very interesting what the latest data Mr. Shashi mentioned, that traditionally in UK, morbidly obese hip, go ahead, do it. But morbidly obese knee, they used to bump off. They would say, go see Shashi, go get do weight. Revision rate is not high, so you need to get on and do it. But still, in a medical legally charged environment like India, we've got a senior advocate coming. I would rather take Shashi's help and cover my back rather than go ahead and try to get into complication, osteoporosis, and then they'll ask, the Supreme Court judge will ask me, why did you not consult a bariatric surgeon like Mr. Shashi? So, Mr. Shashi, thank you so much for your enlightening us. So we will move on to the next session of this meeting. Thank you very much. Round of applause to Dr. Shashi. Just stop sharing this. I think the next part of the presentation here is Bristol Hip Orthoplasty course, which is coming. I'm the India coordinator for this fantastic hip meeting. It's happening on the 24th and 25th of November, 2022. There's a brief video about it. And I really welcome all of you to enjoy this academic feast and register. The world is going through a very hyperinflation now. And if anybody wants to go to Bristol and attend this with all the flight charges and all, they'll be spending easily 10 lakh per delegate. But we are just bringing it around 10,000 rupees or something, which is perfectly jugadu thing in an Indian situation. So please, register for this meet and attend. For me, the highlight of this talk is Prof. Alistair Hart. He's going to talk on couch potatoes and runners, the effect of these two on the hip and knee cartilage, and also biomechanics of the hip ligaments pre and post THR, which will be unbelievable talk. So I welcome you all to attend that. So let me share a little video about the BHAC. So. I think I'll just leave it here. Yeah, I think I'll just leave it here. Anybody who wants to register for this course, please take a picture of this. And with this URL, you will be able to register directly for this course. So thank you very much. So I'll move on to the next part of the presentation now. So this is a hot topic we're all waiting for, the future of hip surgery, really. So just give me a second to get it going. Right. So this section I started, around the COVID time, around 3-4 years ago. So I think a lot of people have lost life in this world, and sometimes it is very important to make sense of what is going on around you and not just blindly focused in work or life. Just to take a step back and just realize, what is life trying to teach us? What is life trying to, what's the message that the world is trying to give us? It's very, very important as human beings to just, step back from all our activities and see. And so I introduced this creativity corner and what is called as a lateral thinking. And, and since then it's been a very popular section actually of this meet. And we know that 20% of activities in life gives 80% satisfaction. We know that a 5-year-old has got 98% creativity versus an adult who has got 20% from the classic paper of George Land and Pet German in 1993. When it comes to performance acceleration, the paradox is that for greater impact, we have to slow down enough to reflect on what we have done and where we are going. This is from Hagelwood et al. I'm nearing half a century now, and it took this long for me to understand what's the meaning of a human being. The being is a creative, wise, conscious self representing unity and oneness, while the human is the form of the physical world and by its very nature has multiplicity, and unity is almost impossible because no human beings are same or agree with each other, and it is commonly due to the human ego. And when the human ego gets magnified into ego of a nation, then wars happen, like what is happening between the Ukraine and Russia. So thinking plays a subordinate role in decisive phase of creative work. Why majority of scientists are not creative is not because they don't know how to think, but because they don't know how to stop thinking. So you take the example of Archimedes, he was in a bathtub enjoying his bath, and suddenly that eureka moment came, so he became creative, he discovered something new. So it's in fact calmness which gives you creativity and the next thing to find, rather than overthinking mind. So we need to find the stop button for our mind, and that can give us a lot of happiness and peace in the world. Last year in Meet the Masters, I introduced the concept of mirror meditation, very simple meditation. And, for this time, we want to focus on the, this moment as an end in itself, not a means to an end. Majority of human beings live as though this moment is a means to an end. For example, if I take a hip replacement surgery example, there are a number of steps. I have to do, approach, then I have to dislocate the hip, then I have to cut the bones, I have to ream the acetabulum, then I have to trial, then I have to put the definitive implant, then I have to close. There are 6-7 steps to do a hip replacement. But when I'm doing the exposure, if I'm thinking about reaming, then I'm not making this moment an end in itself. I'm thinking about the next step. So I'll do a bad job of the exposure. Or suppose I'm reaming the hip, but I'm thinking about, oh, what kind of rubbish exposure I did. I should have done like this. Then again, I'm not in the moment. Yes, ultimately I want to do a hip replacement, I understand, but I have to give 100% attention to this moment now, not to what I'm going to do, reaming, not to dislocation, not to closure. Okay. And that is a simple definition of karma yoga. And I've been practicing this for some time, and this, I believe me, it gives sort of happiness and brings in creativity, because you're in the moment, the creative energy flows into you and you can really think laterally. So we moved from science to metaphysics. Now let us get back to the science. And one such talk on innovation and creativity in action you will see is from our second speaker, Professor Mehul Acharya from Bristol. To introduce him, Professor Mehul Acharya is a professor of orthopedics in the UK. He's the 9th person, in the world to get honorary fellowship, the highest award given by the Indian Orthopedic Association since the inception of IOA, since 68 years. And I'm very happy to say that he'll be receiving this end of this month. And he's a dynamic orthopedic consultant from North Bristol NHS Trust, one of the busiest trauma center in the UK. He specialized in pelvic acetabular reconstruction, complex trauma, complex hip and knee reconstruction. He did his fellowship in complex and revision orthoplasty from Australia, where Mr. Shashi also did several fellowships. He's a great teacher and won prestigious Trainer of the Year award in 2014. He's the deputy lead for skills and simulation in Severn Deanery. He's a faculty in the prestigious Liternal and Avopelli master's courses in the UK. He's a co-convener of the world-famous Bristol Hip Orthoplasty course with Ebert and Tony, and my registrar has taken over that now. And he's going to decode to us now the complex spine-pelvic-hip relationship during THR or hip replacement in 2022. It is completely a lateral thinking and a completely creative idea. And, I'd never thought about these concepts before, but, it just opened my eyes. Unfortunately, Prof. Acharya had to have a surgery today, which was scheduled, but he tried to get it postponed, but he had to do it today. And hence, he was kind enough to record this presentation and send it to me yesterday and answer several of my questions. And over to Prof. Acharya. So I will stop sharing this and I'll share his, the video that he has sent me yesterday. Thank you. I apologize if the last video didn't play for the online delegates. It played well here in the hotel. So I'm not a tech expert, so always it is a bit challenging. So let me try to do it correctly, even if I take 2 minutes, because this is very, very important, presentation. apologies if I'm taking a lot of time because it's a very important presentation. So I'll again check in Ortho TV if it's working. If not, I'll come back and restart this. Please increase the volume to a little bit louder, please.
Thank you very much for inviting me to speak about spinopelvic considerations in total hip arthroplasty. My name is Masters5 and I work in Bristol, UK. What we'll do is we'll start off with an interesting case. We'll talk a little bit about dislocation and safe zones. We'll talk about some important measurements when we consider spinopelvic motion. We'll look at the patients who are at risk, and then we'll summarize and conclude. This is an interesting patient, a patient who presented to one of my colleagues in 2010, 30-year-old female, spinal bifida with some sacral agenesis, quite significant dysplasia of the right hip, with secondary arthritic changes. So she had a second opinion from a hip surgeon, and the decision was to undertake a complex primary total hip replacement. She was templated up to a 46 cup, quite a small cup, and a small DDH stem. The operation was executed. She had allograft from her femoral peg, which was bolted onto the side of the pelvis, and she underwent a hybrid total hip replacement. However, within a few months, she dislocated. And so we can see on the right image, on the left of your image, that the right hip is dislocated in a superior fashion. This was reduced. Again, the next day, the hip redislocated, and you can see it redislocated and relocated. So she underwent revision. Now, the issue here was that she had quite a small cup, and to try and get a constrained liner for this small cup wasn't possible. So she had to wait 4 to 6 weeks for a custom constrained liner to be made. This was made and she underwent revision surgery in 2011, same year. Now, subsequent to this, she kept having pain and limitation of movement in that hip. Hence, for the first time, spine was imaged. And we can see from standing x-rays, weight bearing, both AV and lateral, that she has a significant spinal deformity, and this will have significant implications on her pelvis and her hips. She had ongoing pain, limited mobility, so she had a second revision the following year. This time she was revised to a dual mobility and an augment in a superior lateral fashion. The spine was reassessed again, and this time her spine was stabilized. And for the first time, this patient's pain was better and she could actually mobilize. And this to me really highlighted an important thing. So the relationship between the spine and the pelvis and how these are closely interlinked. So if we look at modern day total hip arthroplasty, this paper here looked at over 200,000 total hip replacements. They looked at revision rates, and the survival of these hip replacements was 94% at 16 years. The most common failure modes for these hip replacements, 25% is dislocation. So in a quarter of these patients, they failed because of dislocation. So can we do something to try and improve these early dislocation rates? Can this be avoided somehow? Well, yes, and this paper here looked at reasons for avoidable revisions. And they found that some of the reasons were poor component placement, poor stem choice, intraoperative fractures, loosening, leg discrepancy. And so the rest of this talk will concentrate on cup placement and how we can try and improve and replicate the accuracy of cut placement. So we all know this paper. This is Lewinek's paper, 1978, and Lewinek talks about the safe zone. It's the 17th most referenced paper in arthroplasty literature. It defines the safe zone as an inclination between 30 and 50 degrees, and an anteversion between 5 and 25 degrees. However, when you look closely at the paper, you find that a third of the patients who dislocated in this paper were within that safe zone. So was it a safe zone for them? Probably not. If we look at a subsequent paper, this is from the Mayo Clinic at 10,000 hips here, and they looked at cut position in those 10,000 hips, and then traced them back to Lewinek's safe zone. And they found that 58% of their dislocations were within that safe zone. So the safe zone, again, is not safe for all patients. So these two papers here went on then to say, well, actually, we should come away from thinking of Lewinek's safe zone, and we should think about an independent functional safe zone for that particular patient. And this is what I mean. So if we look at patient one, this patient has a safe zone where they've got an anteversion between 15 and 25 to 27 degrees, and an inclination of between 25 and 35 to 38 degrees. That's patient one. If we look at patient two, they have a much narrower, a smaller safe zone, which is different to that of patient one. And then we have patient three. So this patient may well have much wider safe zone, or functional safe zone, which again covers a wider range of anteversion and inclination. And so when we consider spinal mobility, it's important to understand that the pelvis can drive or can be driven by the spine. And so if we look at the middle section of these images, we see that this is the ideal position of a cup, 40 degrees of inclination, 20 degrees of anteversion. But we see on the left what happens if the pelvis tilts posteriorly. If it does that, you find that actually what you end up with the same cup is an inclination of 38 degrees and an anteversion of 10 degrees. If we tilt the pelvis the other way, so these images on the right, you find that the inclination increases to 44 degrees and the anteversion to 30 degrees. This is the same cup, which appears changed as the pelvis tilts. So this is what it looks like. So this is in the neutral position, 40 degrees of inclination, 20 degrees of anteversion. And if the pelvis tilts posteriorly, we see that the inclination increases to 44 degrees and the anteversion 30 degrees. And if the pelvis tilts anteriorly, then the inclination drops to 38 degrees and the anteversion drops to 10 degrees. So let's just see this schematically. So on the image on your left, you see what will happen when the pelvis rotates posteriorly. So this is what we see. The pelvis rotates posteriorly, and this is problematic in hip extension or when the patient stands up. Conversely, if the pelvis rotates anteriorly, this is more problematic in deep hip flexion, and this can predispose to posterior dislocation. So let's just look at a couple of examples to highlight this. So this is example number one. This is a patient with a left total hip arthroplasty in the supine position. And this is what happens when they stand up. So the cup appears more anteverted, and it looks as if the inclination is increased. You see that the pelvic inlet has also increased or changed. And this predisposes the patient to possible anterior hip dislocation and extension. Example two, patient two. So this is a patient with a right hip arthroplasty. X-rays in the standing position, but AP and lateral. And look what happens when the patient sits down and flexes forward. We see that there is exposure of the cup, and this predisposes the patient to posterior hip dislocation. So what two X-rays are required? How can we assess this? Well, first of all, a standing lateral of pelvis and spine, and then a seated lateral. And we don't want a seated lateral, as you can see in the middle of the picture. We want a flexed sitting lateral. So that's what we want. And the reasons why we want a flexed seated lateral, firstly, it's more representative of posterior dislocation or posterior edge loading. This is what we want to look at. And secondly, it'll give us an idea of the amount of movement in the lung spine, so whether the lung spine is stiff or not. So we'll move on to some of the measurements, and these are some of the measurements that we're going to talk about, and we're going to run through these and the importance of these. So first of all, we'll look at the pelvic tilt. And the pelvic tilt is an angle between the symphysis pubis and the anterior superior iliac spines. So here we see both left and right, anterior superior iliac spines and symphysis pubis, and we see the angle between them. And this is the pelvic tilt. Okay. The sacral slope, well, if we look at the upper end plate of S1, and we draw a line horizontal to that, the angle that this makes is the sacral slope. Lumbar lordosis, this is something that we're all more familiar with. So superior end plate of L1, superior plate of S1, and the angle between the two, this is the lumbar lordosis. And then pelvic incidence. So this is an interesting angle. So if we again take the superior end plate of S1, we take the center of rotation of both hips, and we draw a line to the midpoint of the superior end plate of S1. An angle at 90 degrees to that superior end plate is called pelvic incidence. And then the spinopelvic tilt. Well, what is this? Well, this is the angle to the vertical that is made with a line that is just looked at the midpoint of the femoral heads, midpoint of the upper end plate of S1. And this important equation is important to remember. So the sacral slope plus the spinopelvic tilt equals pelvic incidence. And we'll look at why these measurements are important now. There's variation in these measurements, and when the group looked at 1,500 patients with end-stage array, they found the variation is shown here. So here you see the ranges of these various measurements. This group here looked at over 4,000 patients with end-stage osteoarthritis, and what they found here is that limited lumbar flexion was one of the highest risk factors for abnormal spinopelvic mobility. And significantly, if the lumbar flexion was less than 20 degrees, then this significantly affected abnormal spinopelvic mobility. This group then took that one step forward, so they looked at 100 consecutive total hip arthroplasty from hospital special surgeries. They had a 1% dislocation rate. And what they did is they worked back. So they looked at these patients who were dislocated, and they found that these patients had significantly less spine flexion, so less than that 20 degrees, which we found. This paper here looked at 600,000 total hip arthroplasties, and they found that patients who had increasing levels of lung fusion, so more of a stiff spine, had an increased risk of dislocation. So if you had more than 3 levels fused, a dislocation rate of 8%. If you had less than 3 levels fused, you had a dislocation rate of 4%, both higher than controls who had no fusion of their spine. So this paper here looked at 139 total hip arthroplasties, and this paper particularly looked at sagittal spinal deformity. And they found that those patients with severe sagittal spinal deformity again had a much higher dislocation rate, 8% compared to the control group. So what is sagittal balance? Well, the sagittal balance is when your pelvic incidence matches your lumbar lordosis. So in a well-balanced spine, these two angles, the lumbar lordosis and the pelvic incidence, should be around the same. And if they are, then this is a well-balanced spine in the sagittal plane. If they are not, and in particular, if you have a mismatch between lumbar lordosis and the pelvic incidence of more than 20 degrees, then this is termed severe sagittal spinal deformity. So just an example of this, here we go. This is a patient on the left who has a lumbar lordosis of 39, pelvic incidence of 36, and if we look at whether they're balanced or not, these are almost equal, well-balanced spine. Similarly, the patient on the right has a very similar lumbar lordosis and pelvic incidence, again, a well-balanced sagittal spine. If we look at these two examples, so the example on the left, we see that the pelvic incidence is much smaller than the lumbar lordosis, and this gives you a mismatch and gives you a hyperlordotic spine. On the right, again, you've got a mismatch. So you've got a difference between the pelvic incidence and the lumbar lordosis, now plus 32, and this gives you the severe sagittal spinal deformity group. These patients are at high risk of dislocation. Does the spine have to be fused for it to be fixed, limited motion, and predispose you to dislocation? Well, no. When we look at the literature, only 1/5 of the 6% of patients that have limited lung flexion have instrumented spine. So you don't have to have an instrumented spine to have a stiff spine. And in accordance with that, that increases the risk of dislocation. So who is the at-risk population? Well, we've seen from some of our measurements that a limited lung flexion of less than 20 degrees. Patients who have a large posterior pelvic tilt, so less than -10 degrees, but the pelvis is rotated back. And then those that have severe sagittal spinal deformity, so a pelvic incidence and a lumbar lordosis mismatch of greater than 20 degrees, plus 30 degrees. And if you look at patients, then you find that actually 17% of patients demonstrate one or more of these abnormal characteristics. If we look at the Venn diagram, we find that 1% of these patients have all three of those parameters. So these are the patients that are at the high end risk profile for dislocation. It's also important to understand that about a third of these patients are over 75. And as we know that as you get older, your spine gets stiffer, and hence these patients change their risk profile as age increases. And so this is important to understand that a patient in their 20s may well have a specific risk profile for dislocation, but as they get older and as their spine changes, as it becomes more stiffer, their risk profile will change. And at the moment, the group by Corin are looking at developing a risk score or a risk analysis. One of the other things we need to really think about, people haven't really touched too much on this talk. Well, it's important defining the target, but the other side of the equation is to ensure that once you've defined that target and you have set parameters, you need to be able to replicate those parameters intraoperatively. And how do you do that with accuracy? And then the other side of the joint, so we've looked at the cup and the acetabulum, but we know that hip joint is made of both the acetabulum and the femur, and we shouldn't forget the femur. And all of these implications about version, rotation, all apply to the femur as well, so these need to be taken into account. So in conclusion, we've talked about safe zone, and we've talked about the luminate safe zone, and how it may not be safe for all patients. And it may be more appropriate to think about a functional safe zone for a particular patient, which is independent and can change with age and as time goes on, or with circumstance. The other thing we've talked about is about thinking about cup position and individualizing that cup position for that particular patient based on their spinopelvic motion. We've talked about recommendation of imaging, so a preoperative standing and a flex seated lateral X-ray and a CT scan to be able to plan this. And then just something to consider from all of this. So if you've got that patient who is at high risk, so those with limited lumboflexion of less than 20 degrees, those with a large posterior pelvic tilt, again of less than -10 degrees, and those with severe sagittal spinal deformity, so a mismatch of greater than 20 degrees, you may think about alternate bearing. So you may think about a dual mobility bearing or a more constrained type bearing. And it's important that we can measure all of these on X-rays. Sometimes these parameters can be measured here. There's a company called Corin who would be very happy to do this for you. And based on these measurements and the scan, they create a plan for you. And we'll put that patient through that range of motion to look at potential areas of impingement, potential areas of uncoverage in standing or flex seated position, and give you a plan which you can replicate during your operative procedure. Thank you so much. Thank you for listening. Happy to take any questions.
That was indeed a master talk for all the orthopedic surgeons here. Truly a master speaking about the future. I never realized that doing a hip replacement can be that complex, and so much of measurements coming into play now. And I think the role of the radiologist is going to become increasingly important going to the future. I'll just take any questions if anybody from the audience has got questions. So he's answered most. So anybody has got, Dr. Raghavendra, you got any questions? Yeah, I think it's very important. In any stiff spine, you need to measure these angles and have the risk before we attempt surgery, because traditionally we did hips and then we looked at spines and then things keep dislocating. So since we've got the angles, parameters, we know the formula now how to avoid dislocation. The best thing is to get all these things. So I always say that the operation table is a place to execute the surgery, not to plan the surgery. All this planning has to happen before. My trainer and my Acharya's trainer, Mr. Anthony Ward, amazing pelvic surgeon, amazing planning. One day we used to sit before surgery, go through the whole thing. And for him, the pelvis, he had a 3D anatomy of his pelvis in his brain. So he would just say, Shri, I'm going to put screw here. And Prof. Acharya has seen that the screw would just go there. So I think it's because of the planning. Okay, that's very important. I think the next talk would be, this talk, every orthopedic surgeon is waiting. So the next talk, every doctor in India is waiting. And we have an amazing personality who's going to join us, I think from Mumbai. So let me try to stop share here. Technology is always challenging. Checking that it's coming live there as well. Doctors were exempted from the consumer protection laws in India. The Indian courts realized that since independence, the number of doctors punished for malpractice by the medical regulatory authorities in India were in single digits. So courts decided to bring Indian doctors under the ambit of CPA. So question arises, was it a failure of self-regulation from the regulatory authorities and all of us? What is CPA 2019? It can be against the doctors or against the hospital. So here there is no limit on the compensation that the patient can claim from a doctor. You can sue at your hometown, no fees for service up to 5 lakhs, no penalty for frivolous complaints that the patient can make on us. And then, the courts are saying that up to 10 crores can be awarded against the doctor in hospital, and that's okay. So in case of a death of a doctor, the court says that, the death of a plaintiff or a defendant shall not cause a suit to abate if the right to sue survives. That means they can come after, even after the doctor's death, they can come after their families and they can attach their properties, which is very unfortunate. Probably it doesn't happen anywhere in the world. Coming to knee and hip arthritis, I know there are some juniors here, so I'll take them through the basics. Arthritis, we know, affects around 20 million people in India. 1 in 4 of them need some kind of a surgical intervention. And we've seen that, COVID has shown that we've got skill shortage. And, we need to really prepare for surgery to get good outcomes. Who wants this? This is an untrained person at a hip arthroplasty. Day 1 surgery, there's a central fracture dislocation. Neither the patient wants this, nor the hospital owners want this, nor the surgeon wants this. It's a really terrible complication. So knee, we know that it's a complex 3-dimensional hinge, and these are the basic questions we need to ask in a knee, problem. And we know that, these are the indications for knee replacement surgery. And these are the types of knee replacement surgery which is possible. We did mention about the newer ones like computer-assisted robotic 3D augmented surgery. And we know now that not all patients, all knees are the same. So many myths that I had to face when I moved to India, the demons I had to deal with. One was that the eyeballing was better than computer navigation or robotics. Thankfully, with the advent of robotics, with 1 millimeter accuracy, this issue is settled. Nobody now argues that robotics is bad, because the people who said computers doesn't work, they were the ones to buy the robot here, and both of them work on exactly the same principle. One size fits all. The truth is that every knee is unique. Looking at X-ray and doing a knee replacement now in 2022 means giving a 2-dimensional solution to a 3-dimensional problem. And you can always plan surgery and table. I was telling Dr. Raghavendra here that you should plan the surgery before. Table is a place to execute, not to plan the surgery. The other myth is that anybody can do a knee and hip replacement. I know I did a UK training survey when I was a fellow, and the registrars there said the same thing. So let's explore that if it's really true. This is Dr. John Insall, the father of knee replacement surgery at Hospital for Specialist Surgery in New York. He said that knee replacement is a soft tissue operation with some bony cuts. He told this 50 years ago. And today in 2022, we are really realizing what exactly he meant. And that's what great masters, they can predict into future and say what exactly is happening. We are debating what he said 50 years ago. Why did he say that? Because he understood the role of ligaments in the knee. The primary restraint to anterior translation in flexion extension is the ACL, but it's also prevented by the medial and the lateral collateral ligament. The posterior restraint to the knee is a PCL. As we all know, dashboard injuries, it gets affected, but it's also prevented by the MCL. Internal rotation is resisted by ACL, but secondarily by posteromedial complex. External rotation is resisted at 30 degrees by the posterolateral complex, but at 90 degrees by PCL. That's the basis of our dial test. But MCL at all the ranges. Valgus at 30 degrees is prevented by the superficial MCL, but also by the ACL. Whereas again at 30 degrees by the superficial LCL, but at all degrees by the ACL. Like each ligament has got more than one function. We all know about the 6 degrees of freedom that the knee enjoys. And to do a knee replacement, I need to do 3 basic cuts: tibia, femur, and the patella. And if I combine this 6 degrees of freedom with 3 cuts, so there are 216 ways in which a senior arthroplasty surgeon can get the knee replacement wrong. So what to speak about a junior who is started on this journey. So the answer is no. If you have patient's interest at heart, a primum non sere, proper training experience is a must to do this procedure. Hence, these modern concepts like navigation, PSA, 3D robotics, and the AR, which I talked about in the first presentation, has come about. We know why he's best because we can measure what he has done. The number of limitations of the human eye. With eyeballing, we can't differentiate, less than 10 degrees of change in angulation. We know in knee surgery that more than 6 degrees of change in varus valgus alignment lead to catastrophic failure of the knee replacement. You don't want a bad day at office to affect the outcome of patient surgery. You want to minimize surgeon error when so many factors at play, and some known, many unknown, like the role of ligaments. And 1 millimeter accuracy is humanly impossible. Alignment versus balance issue in the knee is still not a resolved thing in 2022. So we need these modern, surgical options really, like navigation, robotics, 3D augmented knee, and future AR. So I started robotics, as I mentioned, in Bangalore a year ago. It gives 1 millimeter accuracy, bone cuts done, taking 6 degrees into freedom into account, less soft tissue dissection, less blood loss, early rehabilitation, and they go home early. This is the post-op X-ray, and this is a lady immediate post-op. She's able to straight leg raise and bend and less pain. So that's quite good. Coming to complex surgery, knee and hip surgery, my Indian experience, one of our delegates here asked about the bariatric surgeries that I have been involved. So this was a 60-year-old lady, 120 kg diabetic. She was operated by the top 2 orthoplastic surgeons of Bangalore and Karnataka. Unfortunately, the knee got infected. After 5 surgeries, the primary surgeon gave up. He had to leave her with no joint. She was in a bedridden state with 120 kg obesity, diabetic. Her daughter was unmarried and she was really struggling. She came to me, said, Dr. Srikanth, can you help? I said, this is my training in Germany. If I can't do, then what's the point with that? And, I planned this is the surgery she had on the left-hand side, but she came to me with the right-hand side with the excision orthoplasty. So what were the issues? She was obese, she was diabetic, she had diabetes, and she had 5 failed surgeries before, done by a top orthoplastic guy in Karnataka. She had multiple scars. You can see that I've marked all the scars in the blue ink. So in the last surgery that the senior surgeon did, he couldn't close the knee. So he really struggled. He got a plastic surgical colleague to come, and he had to do a gastrocnemius flap to close the knee. Okay. So, and I knew that if I get into trouble like a senior surgeon, then I have got only 1 gastrocnemius left for the plastic surgeon to bail me out. So she had gross shortening 1 inch. I am showing there, limb discrepancies 1 inch, and she needed a bariatric table and a bold anesthetist to take her on. So I aspirated the knee and it grew E. coli. I planned 2-stage revision. I put an antibiotic loaded cement spacer there, which killed the bacteria. So in around 8 weeks time, and the ESR CRP came back to normal, and repeat aspiration was clear. Then I had to plan the 2nd stage revision. Which hospital? It was a teamwork, combined orthopedic and plastic work. I had to get a clearance from senior physician, nephrologist, cardiologist, a vascular surgeon, a top one from Bangalore who is a very good friend of mine, and a senior anesthetist. During surgery, there were challenges with anesthesia because of her size. And, the type of anesthesia was challenging. It was prolonged surgery lasting 4.5 to 5 hours. So, when juniors take this on, one can run out of steam. So there are massive fluid shifts, and hence she was rightly put in the ICU for 24 hours. I'm glad that the anesthetist there has promised to me, extubated her, send her back to ward after 24 hours. There was issues with quality of quadriceps, which was also dealt with during surgeries. And after many more challenges, I could put this, a rotating hinge knee here. And this is her 2.5 years after the time that she was bedridden and could not walk, and her daughter was really struggling. People say, surgeons operate for money. It's not for money. It is to improve the patient's life. And this gives us more happiness that the patient can walk and they're not dependent on their children rather than the money that they can really give. So second case was another, osteoporotic conundrum. It was a 62-year-old female. And again, she had not walked for 2 years. And she was literally carried by her son into my center. And I can still remember that. She was seen by a very senior prof who's been a prof to me and to Dr. Ramesh Krishna. And he had apparently told the patient, God help you. One of my colleagues had aspirated the knee. It was negative for any organism. She came with 90 degrees FFT. That is, the knee was stuck at 90 degrees and couldn't straighten. I did an MRI. It showed complete destruction of the joint, ACL, PCL, passed from trochanter to knee to the ankle. So I had to plan in staged procedure. First I did the open reduction of the knee and radical debridement with flexible reamers. and put a static cement spacer with a antibiogram with some antibiotics, and all the investigation I sent from the theater came negative. So I was stumped. Fortunately, because of my UK training, I had sent some sample for histology. Dr. Prasad, one of my classmates, called me next day. He said, "Shrikant, this is classic tuberculosis." So that sort of bailed me out really. So I started ATT, and she had a paper-thin quality of bone. Her compliance was poor, although she was in a plaster, she was walking on it. So she sustained an undisplaced supracondylar fracture, and economic status was not that great. And the family said, "Dr. Shrikant, if you put a revision knee, it was costing 3.5-4 lakhs at the time, the implant. And if it gets infected, we don't have money." So, and then, they said, "Please fuse the knee." So this is the Stryker T2, fusion nail. It cost 2 lakhs itself. So what do we do now? We had to think jugaad, out of the box. So I spoke to a few distributors in Gujarat. Gujarat is a land of jugaad in India. And there they said, "Sir, don't worry, for 15,000, we'll do this one." They made a customized nail for 15,000, which I could lock proximally and distally. And, the distal, it was a completely osteoporotic bone, the air shot really. Gave her for ATT for 9 months, and he fused in around 6 months, and she was able to weight bear. So coming to, the last case, this is a 35-year-old IT person. He's a son of a pediatrician, so always more pressure when you operate on doctors' families. He had a road traffic accident and had a left central fracture dislocation. He had an ORIF with quadrilateral plate and anterior column fixation and a posterior column screw, basically a bicolumnar fracture. He developed a perioperative sciatic nerve injury or nerve injury during surgery. It took 18 months for him to recover. He met me in 2018, 2 years after the index surgery. And, he was also 2 inch short, and he had a jog of movement in the left hip because of protrusion. His abductor strength was 4+ out of 5. EHL, EDL was 5 out of 5. That means he had recovered from the nerve injury. The metalwork we plan to remove in 2 stages. First surgery was done in a friend's hospital who has got some interest in pelvic acetabular surgery. We did a proper vascular preoperative check. We had a vascular surgeon on standby and one top vascular surgeon for advice. He said, "I'm in OT, I can't come, Shrikant, but I'll give advice." So we had 2 units cross-match, and we had 2 units of blood grouped and saved. So the anterior column plate was approached by the ilioinguinal approach. All screws were removed. There's a bony layer over the plate. There's, I was near the lateral window, so I had to slightly twist the plate and pull the plate from the lateral window. Once I pulled the plate, it came out happily. But, my colleague was there in the middle window, it started bleeding. And, when these things happen, you sweat because there is an artery there. You don't know what's happening. And I could clearly see sweat from my friend. And also I could see my anesthetist really panicking a bit. I said, "Don't worry, blood is there. We've got vascular surgery and everything." So we put a large mop just to, on the vascular injury, just to stop it as much as we can. And, I informed the anesthetist to start fluids, blood, vasopressors. We called the vascular surgeon on the board because his number was already on the board. So the vascular surgeon promptly came in 15 minutes. He used loops. It showed that the external iliac artery was fortunately not damaged, but just a vein, 6 millimeter rent. So he put some fine sutures and repaired it, and there was no further bleed. So there's no infection there, and we had enough excitement for the day. So we said we abandoned removal of the quadrilateral surface plate and the posterior column screws. I explained this to the patient's mother and patient. He recovered quite well. Mom being a doctor, she was very understanding. Around 3 months later, I went back in again. We planned the second stage. The issue was the quadrilateral plate, which was still there, which had screws jetting into the acetabular floor, were around 4 millimeter. So I had to use a templated plan, and I used a diamond burr to take them out, these protruding screws. Used a posterior approach. I had to do in situ neck cut due to the protrusion. Dislocated the hip very carefully. I took the 8 to 9 millimeter crotons from the patient's own head. It's all evidence-based because even the size of the graft we use matters really in the reconstruction. And I impacted the floor. It's almost like impaction grafting we do in Exeter, and reverse reamed and put an uncemented link up with 2 good screws in a strong bone, and put a ceramic and ceramic liner and Exeter stem for perfect antiversion stability. I just could gain around 1 centimeter length, but I didn't damage the sciatic nerve, so I was happy to accept that. So patient postoperatively was happy. He was able to walk with the shoe rise, and he had a happy outcome. And in fact, he lives in my same closer to my house, and he always calls me. And in fact, just before this meeting, he just called me. Mr. Shashi was here, and he wanted to chat. And he's doing extremely well. Always used to travel with wife and then mother, but now he goes to Goa and Mangalore and all beaches by himself, which is good. So hip, Prof. Acharya had a master talk, And this is just a lot of doctors ask me, sir, I want to go to UK. So how do we approach that? In UK, basically what they're looking at is the knowledge, skills, and attitude. And this is one example where there was an arthritis and a fantastic skill was demonstrated, and a kind of a complex primary revision implant was put. And I think a primary implant was put. It got infected. Then this second implant on the left-hand side was put. But when putting, what happened was the stems which are there were cemented. So unfortunately for the surgeon, it got infected again in around 2 or 3 months' time, and the patient came back with pus pouring out. Now, the problem is once you cement the stem, it's very, very difficult to take it out, because we don't have Oscar in India, which is a vital equipment to take the cement out. And the surgeon was really faced with a dilemma, and the only option he had was to split the femur, split the tibia, and take the whole implant out, and eventually choose a fusion. And he presented this paper in one of the top national meetings, and there was the son of Professor Chittaranjan Ranawat, who did operation for Vajpayee, our prime minister, and he was in the meeting, I was in the meeting, and then we raised the question, why did you cement in the second time? It makes so difficult. You could just put cement around the metaphysis. And then Prof Ranawat is both father and son, they don't mince word. He said, I agree. Why did you do that? You could have just saved the knee, given one more implant which can bend rather than fusion. So I think we need to be really careful how to avoid being in the cesspool. Follow the guidelines and protocols and SOPs, even if made by your own institute, to the hilt. Have an algorithmic approach to any problem. Law expects you to keep your knowledge updated. Lack of common and widely available knowledge certainly weakens your defense on the grounds of error of judgment. When in doubt, seek a second opinion, very, very important, and document everything. There's no, shame in asking a second opinion. So we know about Bolam versus Bolito and Montgomery. Fortunately, Indian courts still Bolam law is being applied. Only 2 cases we had a Bolito applied. UK, I think it's moved towards Bolito. Contrary to Bolam test, Bolito test expresses that the court must not accept the defense argument as being reasonable, respectable, and responsible without first assessing whether such opinion is susceptible to logical analysis. Bolito test was upheld by Supreme Court of India in 2 cases, the classic Samira Kohli versus Prabha Manchandani and Binita versus Lakshmi Hospital. In Montgomery, it's all about consent. It was Montgomery versus Lancashire in the UK. It changed the perspective of informed consent by upholding the patient's decision to know what they want and not the doctor's decision to decide what he wants for the patient. So how to choose the best option for a patient without falling foul of the law? Defined standard of care should be adhered to. Guidelines should guide, recognize your limitation. Competence in doing the procedure treatment should be most important. Don't hesitate to refer. This is from a lawyer, not from me. I borrowed it. So explain, and document. Alexander Artemiou said that there are 4 phases a surgeon faces when during a very difficult surgery, extreme hemorrhage. First is, why did I get involved in this surgery? Second is, why did I become a surgeon? Third phase is, why did I become a doctor? And fourth phase is, why was I born? So we should really not enter into such regions really. So my take-home message will be CPA 2019 is a draconian thing, and we lost a Bombay High Court case, as all of you know, a few months ago. The get it right first time is an important evolving concept in orthoplasty. The insurers, the patients, the legal fraternity will demand this more from us in the future and the present. Revision knee hip surgery is a complex area of work and take from 2 to 6 hours, as I explained. Patience, resilience, passion, teamwork, experience is very much important. One can run out of steam easily, and training is a must to perform these complex work to acceptable standards. I tell juniors that don't watch Umidi or YouTube and try to become a surgeon. You really get into trouble. Mr. Steve Ireland is one of the top orthoplastic surgeons, like Mes, probably much bigger than Mes. But he refers, he described transverse acetabular ligament for all orthopedic surgeons in the world. He does only primary hips, refers all revisions to other surgeons, and there's no shame in it. When the top guy in the world can do it, it's not shameful. And UK, all infected revisions referred by revision surgeons to consultants with special interest in infected revision work. There's no Macoism that, I'm a Maco, I can do head surgery and toe surgery. So in conclusion, dear friends, Life is short. COVID has drilled that into us. Why take needless risk? Combined work is the need of the day. And younger surgeons, I tell, don't again perform surgeries. Look at your YouTube, because these are complex areas. CPA 2019, we got a hostile judicial environment, and I think some agencies are trying to take us out. So we need to be united as doctors and not show apathy and win this case against CPA 2019. When things go wrong in India, we get roasted, jousted, and sadly, we get still attacked by patients' relatives in India. There's a popular saying in UK, when in doubt, refer to the appropriate trained specialist. Let's work together for less stress and hassle-free life for ourselves, dear friends. These are the references, my talk, and I ask any questions, welcome, and also seek your support to serve these patients better. I like this quote from Aristotle. Yeah. Any questions in the floor? Sorry, sir, what's the call? Yeah, 2019. Yeah. I think with government there is some controversy because the fees is not charged. But we have seen number of people who have done free eye cans and free cataract cans and things like that. And they're very with great this one. When eye has been infected, eye has been lost, they've been sued as well. So, but the patient didn't pay a penny to get the surgery done. So that's equivalent to the government, but still courts have sued them. So I think, although you say government doctors are out, but, we never know, we're still not out of the woods. So maybe Professor Ramesh Krishna could enlighten, or is government doctors exempted from CPA 2019?
That's what all of us government doctors are exempted, because the patient does not pay any money for the hospital or to the doctor as such. That's what we have done. But we have not had any such litigations against the doctors, government doctors.
Yeah, I think that's the law. So I think because there's no fee involved, I don't think government doctors should be subjected to Consumer Protection Act. But I think I'm no expert. We have the best expert in India really with us now online. Thanks to Ortho TV, the technical issues have been fixed. I request Dr. Arun Mishra, I welcome him to this meet. And I request him to unmute himself. And sir, welcome, sir. I'm very sorry about the.
No, not at all, not at all.
As a doctor, I understand exactly where the shoe pinches. I'm not technical either. So welcome, sir.
Thank you very much, Srikanth.
Can you hear me, sir?
Yeah, I can hear you. I can hear you.
You can hear. Can you increase your volumes a little bit louder, sir? If you can just increase. What I'll do is I'll stop share. I'm sorry.
You can start, Srikanth.
Sir, there's one question which the audience asked. Are government doctors exempted from CPA 2019? Kindly enlighten us, sir, while I put the slide.
We'll start with that question. We'll start with the answer to this question. Let me tell you the case of your Bangalore itself, a government hospital. Will we resolve all the questions your people have raised about the government doctor is in CPA Act or not? But with this case, you'll understand even government doctor comes under CPA Act. It was the case of your government hospital of Bangalore, where this guy has been referred by some physician working in the same government hospital, having a backache to the orthopedic department, and where the houseman has given an injection for relieving a pain, and later patient got septicemia, remained in tertiary care hospital, in private hospital, and died after 2 months. And 28 crore compensation case has been filed, not only against the referring doctor whom I presented, but even the unit head who has never seen the patient in government hospital, because normally in government hospital, it's unit head whose name is already there in the form. And naturally other corporate hospital, where when I have taken the discharge of this lady of a government hospital because she just reported the patient, but the unit head was brought in a purview of the law by the court in his discharge application, where court has observed, even if it is a government hospital, you come under the purview of CPA Act because somewhere you charge some patient even with the form fees. So that is already a definition of consumer which get proven. There's nothing like a free, 100% free in that hospital. Secondly, they said being a department head, it is your responsibility to see the disinfection of the particular department, sterility of department, and infection happening in department, whereas liability cannot be resolved So you need to fight this case, and that case is still pending in National Commission for 28 crore compensation. So government doctor per se, even multiple judgment has came, very much comes under the purview of CPA Act. There is no question that they are being immune under CPA Act. Consumer Protection Act very clearly says that if it is 100% free, means not a single patient is charged, then only they are protected under the particular CPA Act. Means even if you are charging one patient and giving 99% free of charge, then also that free of charge patient can go to consumer fora under the CPA Act 2019. So you, an all government doctor very much comes under CPA Act, hospital and government doctor.
Thank you, sir. So I just want to give a little preamble to this talk, sir. So because we couldn't join earlier because of the technical glitch. Why this talk? What was my thought process behind it? We know that medicine and orthopedics continuously evolve. We had 3 fantastic talks about future technology like augmented reality, the new hip axis, and then some new injection which has come into India. So what's true yesterday may not be true today. And due to audit and research, medicine is continuously evolving. And research is the method of finding new things to do. The best example of a research is the corona vaccine, which really saved billions of lives in record time. So research, simply equals saving human lives and improving human lives. Without pharma and implant industry pumping money into research in medicine, human life can't be saved. This is the bottom line. So this nexus, as people describe it, is sacred nexus. When this nexus doesn't become sacred? When does the sacred nexus break? How to navigate nexus in the eyes of the law and the National Medical Council. So that's why this talk was designed. So I'll just briefly introduce sir. He has got an unbelievable CV. Always a glitch. Anyway, so senior advocate Dr. Arun Mishra, these are his qualifications. It'll take 2 days for me to go through his qualification. He's a practicing advocate of the Honorable High Court of Maharashtra and the Supreme Court of India. He's a medical legal consultant, a criminal and corporate lawyer. He provides a doctor's risk medical legal service, a service which walks the talk. That's all I can say. He's a LLM crime from Mumbai University. He has got 3 degrees in medicine, microbiology, and law. He has 3 postgraduate degrees in medicine, yoga, and law. One of the best medical legal consultants in India with success rate close to 100%. He has handled more than 16,000 medical legal cases in the last 16 years with the use of latest medical legal laws, High Court and Supreme Court judgments. He has authored a book, Law of Medicine, which runs into 8 volumes. His aim is to provide awareness, unity, and confidence among doctors. He has got something called Voice of Doctors, an approach to bring the medical fraternity together, because unity is not a great thing in India. I was speaking to Professor Nandimat, professor of law in Bangalore, and he said that a doctor trained in law is your best friend. And, Professor Dr. Arun Mishra fits into that bill really. So over to Dr. Arun Mishra to guide us about the ideal doctor-pharma relationship in the light of new National Medical Council Guidelines 2022. Over to you, sir.
Thank you, Srikanth. And to all my delegates here. And definitely, I will touch upon the very raw topic which has not been touched by many of the speakers, because this is the topic which is the need of hour, because of lots of gifting and other things have been very well watched by the government authorities. And you will agree with me, because of the Dolo case which has gone up to Honorable Supreme Court, where 1,000 crore of exchange of money was presented to the court and to the government. Government was very, very alert, and I don't know how much delegates here knows about this or not. On 1st July 2022, very recently, a few months back, post this particular case, Government of India has amended their income tax law, and they have brought pharma under the domain of income tax, where the gifting got involved. So let me start with that particular law, which has been very recently introduced by the Government of India. Government of India's researchers found that around 20,000 crore gifting is done by pharma company altogether in a year. Approximately 10% of the turnover of the pharma company to the doctor. Actually, it is open secret. And they found that 20,000 crore was shown as expenses by this pharma company, where the other side is not getting any income. So government was losing around 30% of tax on that. So it is 6,000 crore rupees lost to the government in the form of tax, because one side it is expense, but other side there is no income. And just to curb that, government has introduced new law where they said if any gifting is done to the doctor or whoever, it is mandate for the pharma company to cut the TDS on that. Like UK, USA, even if visa is given to the doctor, that comes on a record. So to curb all this nexus, the new law has already been introduced in the market by the lawmaker, and that's the reason where pharma companies now searching for the loopholes to naturally get connected to the doctor, because now they cannot directly give what amount of gifting they can show as expenses, because 20,000 crore odd cannot be, and doctor will never like if it not TDS has got an income is shown to him by any authority, because that will direct evidence for the nexus of pharma company and doctor or gifting, which is said to be a bribe by the law of the country made by NMC, and earlier it was by MCI, where gifting was curbed by these laws just to avoid such a nexus between pharma company. We all know about that, which was introduced in 2016 when our Ethics and Ethics Act was there, which is still existing. Because I'm not going to speak much on NMC. NMC, I'm just going to give a highlight because NMC law is not yet formulated. NMC draft has came, but not been notified. So we are not governed today by NMC draft, because there's a high possibility that draft may get changed. Because lots of suggestions already gone to the NMC, which is already in the process of analyzing every point after the draft was public, given in a public domain. And once it become finalized, then draft will come with some new color as a notification, and then it will going to replace the old act. Till the time this draft does not come, the old act of ethics and ethics regulation 2002 is still existing, and that is the good act. They have adopted exactly the same with little modification, but old act also been amended and modified very recently, when the pharma companies nexus was well picturized and well shown to the world. And thereafter, the amendment done by the MCI those days, now NMC, under the act, have brought a particular section of gifting itself, where they have barred every doctor to take a gift of any type, wherever there is involvement directly or indirectly, action has been initiated against the doctor. We all know all this thing. When Gujarat, many doctors have been suspended for 3 years for accepting the gift from the pharma company. Yes, just to avoid the confusion, they have defined the punishment depend upon the amount of gifting, so that people will get a warning with a simple punishment. In olden acts, they have already defined that up to 1,000 gift amount, X amount is going to be the punishment. With more than 1,000 other things, they have already categorized that, and they have said direct or indirect taking or any connection with the pharma is absolutely bad in law. So if you see the act, they have taken care of every possible loopholes which pharma can enjoy for bribing a doctor for the purpose of their benefit or a prescription or whatever it may be. So that is all is already been defined. Yes, one loophole which pharma company later has been brought out because of lot discussion, because they don't want to lose the big chunk of a business and good number of a doctor which they have already on their rolls. So they have used the loopholes of the research part, which was there allowed under the law. That for the purpose of a research, pharma company definitely can engage the services of professionals, and they can do some give and take. My doctors are not aware of all this, because they just think that we have signed the agreement and we have been supported by legal team of the pharma company with a clear guidance that research amount cannot be a problem for them. But let me tell you, all my friends who are here, that also been brought with multiple riders. And my humble request to all my delegates here, please go on internet, download. It is just 1.5 page or maybe 2 or 3 page. It will take us 20 minutes to read complete ethics and ethics. And for the pharma, interesting, it will take just 10 minutes to read that. They have put so much so rider, even in research, that once you read, probably you will not sign any agreement with any pharma company for the purpose of research purposes. Because they have clearly said that every RMP must confirm prior to joining as a research assistant or whatever pay, that following norms are completed or not. Means what ground the research has been initiated, what facilities have been provided, how and what type of research they are going to do. Are these researches are being recognized by the law in a country with various department of a law? Are people are being used as a guinea pig because of the prescription and various other domain? And they said if all these are in a place, then you can join as a researcher and can charge your professional charges. But that role, if you see, yes, all major pharma companies have already got their R&D department. For them, it will not be a problem because they have established R&D department. They may be following all the rules and regulations. But in my opinion, I have seen the smallest company, the propaganda companies, and the small pharma, upcoming pharma companies, they don't have that much structure built for the research purpose, which they say that it is a research domain, and they are signing, and you are blindly signing an agreement taken on white money on a check, is definitely, once it has been audited, can be a problematic to my doctor. That is one loophole which has been brought under the law, which pharma companies utilize in a larger way. But now, since people are becoming more and more aware, it becomes very difficult for the doctor and for the pharma company to continue the same. And after this particular amendment of Income Tax Act in July, now pharma companies left with no option to go more toward the white transaction of money. Here, even if at all they're paying, they need to cut the TDS on that. There's no option to that. They have to show that it is your income. You have to show in your income tax account that these are the amount I'm receiving for the pharma companies in the form of income, because now white cash transaction is going to be banned. Many of the time, pharma company are using that loophole that they're taking a signature on some research product only for the purpose of showing to that. And major chunk of amount was given in a cash. So there's no transaction of amount under the account, so income tax was not applicable. But now government has curbed that also. Even pharma company cannot bring that much of cash because cash rolling has now become difficult and cash transaction is going to be really tough. So pharma company also need to cut a TTS. All need to be on a white. And in that scenario situation where there is a nexus between pharma and doctor and some audit has happened by default or on anonymous complaint or because of some anti-social activist complaint, or maybe RTI got filed and some revelation happened on that ground, or could be because of rivalry, there is a possibility that if any complaint goes to even to the NMC, the audit is going to done about all the accounting where transaction has happened. And if at all doctor found to have a guilty, then there is going to be severe punishment. And let me tell you, my friend, the punishment now started differing in our country. Pharma defined punishment was there, but now the new NNCIP draft has brought 11 types of punishment, which was earlier 3 punishment, which was just simple a punishment either of the warning or suspension of a medical registration for a few days or month or year, or could be termination, which was the last option. But new law has got 11 types of punishment, and to the extent of a termination of registration also, where the nexus can be proven evidently in between both the people. No doubt that other IPC section may also come in the picture. Corruption Act may also come in the picture because these are known to be a corruption, and various other act is going to jump in in such a scenario where both the people are going to be, I'm not scaring you all, but I'm trying to make you understand that this is the truth of today. Before you take any assignment and assign any paper, please verify as per the norms given under the Act so that you will be safeguarded because you got a qualification which speaks by itself and that is precious to you. Only on that basis you are doing a professional earning and other things that need to be secured and past we have already seen. So my humble request to all my colleagues here, please go through that single page, very beautifully defined. That is again adopted in an NMC. And we need to be very careful because as you all and Sashikant has very rightly said that evolvement, there is already medicine is evolving, things are evolving everywhere. So now since because we are already in that process, we need to be very careful. Let me turn down again to the relation between the implant company and the or a pharma per se and a doctor. Let me bring you one more fact. We are lucky that somewhere the lawmaker has thought about you. But to make you aware about this also, the Consumer Protection Act 2019 has introduced a new chapter of product liability under the CP Act. The product liability chapter is so beautifully defined with all sort of penalties in that. And they have very categorically said the user of that particular product, which is either having a manufacturing fault or otherwise, liability is going to be on service provider also who are using the product. Like in Johnson and Johnson's case, what we have seen where the metal, the implant has caused a huge damage to the human body. In a foreign, there is a billions and trillions of compensation given. In India, again, it was negotiated and the compensation been given because human body got affected because end of the day, it is a foreign material itself we are putting in human body, either of some complication, maybe erosion of a metal, maybe erosion of something that can lead because for the profit purpose, lots of manufacturing defect, lots of metal, cheaper metal, or otherwise maybe used by many of the companies which can cause a damage. And in that case, service provider. See, manufacturer is the one which was earlier responsible for all these things. I'm talking about those days in Johnson times. But nowadays, for all sort of materials, CPI Act has said that for liability of the product, even the service provider, the end user who has given to end user is responsible. But one place they have given a exception to the professionals. That is one thing which can be in a court of law, can be interpreted in the way we want, and can be a great rescue to all my professionals and doctors because they said implant put in a body by the professionals, by the doctor. If they're not aware of this, they will be exempted from this liability. That is mentioned, but we don't know how and what way law is going to get interpreted when the matter goes to the court of law. Because once any matter goes to the court of law, it's all councils who not only interpret the law made by the state parliament or a statute, but also connect other laws with that and give a bigger picture to the judges so that they take a decision on that. We don't know what and how things are going to be interpreted, but one thing is good at a plain reading of the Act, what I personally understood that we are exempted from product liability because lots of implants are used in human body, including for smaller surgery of a cataract, or it could be anything. So product can be anything, maybe a lenses, maybe a implant, maybe a metal thing, maybe anything. So that is one thing which we all need to remember when we talk about CPA. As I said, with pharma and access, we need to definitely be very clear about the same. Yes, pricing again has been very categorically said under the new CP Act that you need to disclose everything to the patient. Earlier, if at all I have spent for 10 rupees an implant, we have charged 15 rupees was taken, not been very seriously taken. But now MRP word has been introduced under that. Furtherance to that, not only MRP, but the competitive price has been introduced under the CP Act. They have said that each items will need to be given invoices consumer must be disclosed about all such a facts and all. So if you start reading the CPA 2019, their rules, you will surprised to say that the lawmaker has tried to curb every possible thing where consumers has been, rather I can say, cheated or been exploited per se. Including, I don't know how many doctors of mine knows this law. They said not giving an invoice in the form which has been given under the law. They have already given an invoice format under the CPA Act. In the format assigned is going to be treated as defenses and services. So not giving a bill or invoices per se is deficiency service. Further, they added not in a particular format. Means if I go with that particular thing, not only for the OPD purpose we need to give invoice, for IPD purpose we need to give invoice, but also for all the items, disposable, non-disposable things we have used for the patient where we are charged, need to be disclosed to the consumers. So lots of changes have been brought by the lawmaker and it is fast. Even the lawmaker knows that technologies are going very fast and that need to be taken care of. And for the purpose of same, every time, even the lawmaker are amending their laws, and which has been seen today. Let me give you another example. When I talk about profession indemnity policy, let me connect to the defense part also. If you see the profession indemnity policy of our country, which was introduced in 1991 when the professional was brought under the CPA Act, I'm talking about olden CPA Act of 1986. In 1991, first time the policy was introduced by the underwriter for the doctors and for the hospital. And those days, things were different. Underwriter of insurance company who have been given responsibility to write the policy were not aware about the medical development and things. And that the reason, whatever to safeguard the insurance company from the claims, they have made a policy with a lots of exclusions in that. And that policies are still existing. And worst part that my doctor never read the policy. And today, even out of hundreds of delegates here may have got a 10 years old policies, continuously renewing every year, maybe 12 years, 15 years, 5 years. They also don't know what is mentioned under the policy which they are buying for their protection. And insurance companies are very clever. They put such a riders under the rules and regulation, which you don't read and you don't know. And when actual time comes for the compensation, they utilize that to repudiate your claim. Same happened in medical claim. We have all experienced in medical claim. They have introduced such a clauses that consumer are not aware of that while buying the policy. And when they go for the claim, they come with that particular clause and they reject the claim. Same happened with professional indemnity policy and error remission policy. In those days, technology was not there. In those days, development of medical science was not there. Things what were available on the basis of that policy was made. And still, I have found in our country, same policies are continued, even if it is made in 2000 by the private organization, private player in insurance companies, or a government insurance company in 91 or 95. The same patterns today also are continued. We don't look to that. We just buy the policy and we don't read the exclusion clause. My humble request to all my doctors here, please read it properly, because once the claim comes, let it be, as I said, orthopedic department of a government hospital of Bangalore been sued for 28 crore. All the doctor, hospital, even the private player where later patient got admitted in tertiary care center for the compensation of 28 crore. Suppose you get a notice of 10 crore also, it is going to be a sleepless night to you. Suppose you got a policy of 2 crore and you got a notice of 2 crore, you think that insurance company is going to take care, but you don't know they are more clever than us. If compensation goes against you for 1 crore also, they will definitely come with some reputation clause and 1 crore you need to pay from your pocket despite of having a 10-year-old policy. And my humble request that since we are already developing, we are developing countries, medical sciences are developing, I have heard that lots of new technologies, innovation has already jumped into orthopedic department. It is a time that we need to understand this, that which policy is going to be best. I, being a doctor, was knowing this. I could able to read all this because now it become my profession. Once I have surrendered my medical degree and opted for this and started my own organization as a rightly with Srikanth and Neeraj, as they are all my part, with the Doctors Risk Medical Legal Services in India in 2005, 18 years back. In a journey, I have learned all this thing. And then I started discussing the same with various insurance companies, top bosses, to come to such a policy that my doctor should not be cheated and everything need to be covered. And I proudly say that we reached to that. And today in a country, you will find the policy available to every single doctors here. Let it be error omission policy or a professional indemnity policy individual. We have convinced the government insurance company like New India to come out with such a policy only for the doctors members. Reason behind that, they don't want to change across the country. The same policy on a policy bazaar, you will go for suppose 3 crore, you need to pay not less than 30,000 plus GST. They have offered us in hardly 20,000 rupees. For 2 crore, they have offered us in 15,000 rupees. 1 crore, 15,000, 2 crore, 20,000. Very, very cheaper rate. But they have covered the major part. New India has covered every latest technology. They have mentioned on their policy itself, because we wanted that they should give a letter to our insurer. And they have given in writing first time that all latest technologies, latest innovations are being covered. Second opinion, online consultation, everything is covered. Cosmetic, all types of cosmetic is very specifically mentioned, is covered. We made them understand that legal fees are going to be trouble to my doctor, because now, because of new Consumer Protection Act, complainant can file a complaint where he reside or work for gain. Yes, all India cases are going to happen. Now it started already. Sitting at a Bangalore, if at all you have treated a patient of Mysore or you have treated a patient of Hyderabad, the patient can file a complaint at Hyderabad and Mysore also. So new law has allowed them to file complaint wherever they reside. So it can be Assam, it can be Bihar, it can be anywhere in the country. And you need to have a legal people to defend you there. And the legal fees are very high. And looking to that, we made them include that under the policy. If at all my doctor is insured, even the legal fees you are going to cover. And they are agreed. You lose the case, then compensation and legal fees. You win the case, then also legal fees is going to be paid by insurance company. The insurance company, New India, has agreed to give 1:1 policy, means highest most premium paid policy, means 1 case of 1 crore or 10 cases of 10 lakh, everything is covered. Any number of cases are covered. They agreed to come for out-of-court settlement in indefensible cases to safeguard the reputation of the doctor. So they are safeguarding a reputation by offering an out-of-court settlement. And first time in country, let me proudly say that they agreed to come for cashless policy. We will never find in a country a cashless. Cashless means what? If claim has been given by the court, suppose 1 crore, and you don't have a money, then insurance company will go back, because they will say that it is a reimbursement policy. You pay from your pocket, then come to us, and then they will repudiate. We know this all tactic, so made them bring out a cashless, and they agreed to that under the agreement that if court gives the order against the doctor, amount will be paid to the claimant directly by the insurance company, and doctor will not be held responsible for that purpose. So first time in a country, out of court settlement, cashless, 1:1, legal fees covered, all cosmetic covered, latest technologies covered, online consultation opinion covered, and it is available on doctorsrisk.com. We proudly say this because we were knowing that what are the, so all the doctors sitting here, my humble request, go and read your policy. And if exclusion clauses comes out all this, please don't continue that. You can change it. Yes, one great point is that IRDAI regulations are very clear. It is not an insurance company, it is a regulation done by IRDAI. IRDAI says, suppose you have got one policy and you have bought another policy. Suppose it is of 50 lakhs, you have gone for another 50 lakhs and you have intimated both the insurance company, then your claim ratio become 1 crore. Means tomorrow up to 1 crore you are going to get a payment. Both the policy is going to come in picture. So first take 50 lakhs from here, then 50 lakhs. So both will be going to be effective policy. Same happens in medical claim also. Now IRDA further says that retroactive date must be given if at all claimant wanted or customer wanted. Suppose you got a 10-year-old policy continuously with you and you don't want to break the 10 years old pattern and you want to change to New India. Yes, your policy is continued. Submit all your 10 years old policy or 1 year, because last policy will have a retroactive date. Submit last year policies to show the continuity, and the new company will take a responsibility of all 10 years claims. If at all they are all going to come under the retroactive date consideration. So this policy is covering a retroactive date also. One of the beautiful policy available on doctor.com. I brought the difference of indemnity policy because I heard Shrikant was talking about the latest technologies and latest innovation which we are bound to use and we really wanted to use, and lots of newer things are coming, newer implants are coming. Tomorrow it should not happen that insurance company takes the ground of rejecting the claim that latest technology is not good, because their underwriter were those days were not aware about such a development in that. So coming down again back to the medical legal issues related to the pharma, all my friend here, in changing era, let me tell you, cases are going to filed against every professionals rampantly. Reason behind that, the filing complaint become easy in our country. Everything become now online, like digital health. It is like a digital legal remedies. So even CPA have made very easy for the complainant to file a e-complaint. One can directly go on the internet, no need of going to the court. Directly go on internet, submit their requisition, submit their claim, and submit to the government. Claim is filed. Because up to 5 lakhs rupees consideration paid by the consumer need not have to pay a single penny. Means suppose hospital bill is less than 5 lakh rupees. He paid to you less than 5 lakh rupees, which is higher possibility. Then they will not have to pay a single penny for filing a complaint. Otherwise, 500 rupees they need to pay, but not a single penny. They get a free advocate also. On the online itself, they need to say that I want to engage advocate, but I don't have money. So they will be guided to the legal affair department. They provide the advocate also. So filing a complaint becomes very easy in our country now. They just need to go on internet, and you'll agree with me. All youngsters are master in internet. When they came in this world, they were having a toy as a mobile. So these age group of 25 years and 20 years and 30 years are a dangerous people because they work on a consumerism, not on a trust like olden times. If they choose you for the purpose of a treatment, then they know the remedies also. And greatest change what I personally have experienced, that the decision maker of the house has changed now in our country. Earlier, parent used to take a decision for anything and everything in a house. Today, 25-year-old daughter and son takes a decision for anything and everything. You buy anything in a house, if you plan for travel also, or you want to go to health for the health benefit to the doctor, they are the people who takes a decision. And that is the reason complaint has gone very high in our country. Filing a complaint in the medical council is too easy in our country, because one tweet on PMO house, one tweet on health ministry, or a mail to any authority get diverted to medical council, respective medical council, and respective medical council suo motu take the case and send a notice to the doctor, because they need to answer it, that what action they have and what process they have initiated. So filing a complaint in medical council is too easy. Filing a complaint in the consumer forum is too easy. About the police complaint like criminal liability, we all know that from childhood, we have taught that if anything happened, rush to the police station. And today, if anything happened, every people rush to the police station. And once they reach the police station, they are very smart people and they take their complaint, because they also want that such a professional should come to their police station. And that's the reason why criminal, yes, I do agree that court wanted to protect the professional, and Honorable Supreme Court came out with a multiple judgment where in criminal liability we have been protected because beautifully narrated in the judgment by Honorable Supreme Court that human body is a complex machine and medical science is a complex science. Hence, medical mishap, even in the form of death, doctor or professional must not be held criminally liable. So beautifully narrated. Means we have been protected by the law in a criminal case because they have defined the occupational medical negligence and the professional negligence. Like a driver, if they kill someone unintentionally, 304 applies, same applies to the doctor. But professional, when they need to apply a criminal liability, it needs to be gross or high degree of negligence, which is rarely happen. But yet, law very clearly says that experts of the field must decide. Judges are not expert in medical science, advocates are not expert, police authorities are not expert. So what lawmaker or what Supreme Court, Honorable Supreme Court said, let it refer to the expert for opinion. And if experts comments on that, then case can be registered. So criminal liability, yes, let me add on to that when I talk about criminal liability. The law is also evolving because of the new interested lawyers. So interpretation of the same section is done by different way. And today, the 304 has been widely interpreted in criminal cases related to medical negligence, which says causing a death without intention, with knowledge that particular thing has led to that. The knowledge component is so much interpreted by the lawyers and the police officer to bring my doctor under non-bailable offense because it attracts 10 years punishment has been widely seen in our country. So yes, criminal liability, civil liability in the form of consumer law of torts, medical counsel liability, all is there. But yet defenses are being there. As I said, the best defense, which maybe have been spoken widely by the many of the speaker, is keeping a medical record. Focus on a medical record, my friend. If you are good in a medical record, I'll tell you nothing is going to happen to you. Let me give you just one case. Neurosurgeon posted a patient for LP, done LP, patient died because of brain hernia. The allegation done on a doctor that inhuman treatment was given to my sister. Complaint gone to consumer fora. He narrated that when this procedure was done, I found that my sister was shouting with the pain, crying with the pain. Two people were holding a doctor is doing some procedure from back, putting a needle. Doctor has defended himself, saying that I have followed a standard protocol of treatment. I have used the local anesthesia. So there is no question that pain can inflict. But when medical record was observed, it was utter surprise that nowhere LA word or local anesthesia word was mentioned in a medical paper. And in absence of that, court presumed that local anesthesia was not given, God against the doctor. My humble request to all my colleagues here, please focus on medical record. More you focus, more you'll be safe. That is one of the greatest defense which my doctor have got. Or before giving a medical record to the patient, always consult your medical legal expert. Audit your medical record. My humble request, audit your medical record prior it has been given to any person. You have got enough time. Law has given a good time to you. Even if at all police wanted immediately, you can buy it 2 hours and 3 hours. And you can exchange on various technology with experts in the field to see that everything is mentioned in the paper or not. Second, in cold cases where patient comes and demand a medical record, you got 72 hours as per the law. You can take a letter and tell it come after 3 days. 3 days is enough for you to audit your paper. But auditing of paper is going to save you a lot. I'll just add on to one case to you to make you understand why auditing become very important. There's a case where ENT surgeon has posted a patient for peritonsil abscess. 2 o'clock is admitted. A lot of time orthopedic do, if they admit in morning and discharge in evening by doing a plasters and all. So morning he 2 o'clock admitted a patient, send an investigation in the same pathology of the hospital. 4 o'clock got a call from pathology department. Everything was normal. Posted a patient at 5 o'clock. Medical mishap happened. Patient collapsed. Died in OT. 7:30. After making all the papers, death was declared. Police intervened for the postmortem. Record was given to the police, and that time my doctor was not having a sense to add a pathology report with that medical record, because it is the routine habit of every hospital to put a medical record by the nurses in late evening or next day morning when it arrives to the department. And in such a cases where emergency, and always remember this pathological report is the property of the patient. So you don't have any opportunity to know what is that time investigation. And since that paper was not there, and in this case, physician friend was called to resuscitate the patient because it was a case of ENT surgeon and anesthetic. But physician was called to resuscitate the patient who has helped the doctor, was also brought in the purview of the law. Reason was very clear. The medical opinion given by the expert saying that when growth was observed, clear indication of pulmonary edema, why diuretic laxatives given after 45 minutes. It is not that it is not given on time, but while writing probably particular in timing would have been changed, and this was done by the physician. So he was brought because of that. And one more comment, either investigation not done or not been documented, because my doctor were knowing that without investigation, my doctor is not going to do a surgery. But since report was not there, they need to write. So the report was not there, so they either not documented. But in court of law, the PP has argued for almost 45 minutes to change the section from 3048 to 304 planes, saying that without investigation, they have done the surgery. So there's a knowledge that if suppose patient has having some blood disease, and without investigation, you proceeded, and because of that blood disease, patient had died. So you got a knowledge. And that has happened. So 10 years non-billable. So documenting investigation report and IPT paper again become important. So medical record maintenance.
On the issue of documentation, sir, in my UK training, always it used to, they say if you don't document, it's not happened. That is law. But when I discussed with a high court lawyer in Karnataka, he said, you should not document everything. You should just leave it neither here nor there, so that I as a lawyer can defend you either this way or that way. What would you say to such a kind of?
I'll tell you, which is as a protocol need to be written. The argument, definitely lawyer get a benefit because no one is expert in the court of law. So whatever been presented is been accepted in the judiciary also. But we can't say that opponent advocate is going to be fool every time. If opponent advocate is smart enough, he also can take the same ground to argue the same way what our advocate wanted. So wherever, but don't document which need not have to be documented. One thing I have found that being a doctor as a honest personality, they write anything which they have done for the patient. I'll give one beautiful example of a corporate hospital where road traffic accident, got admitted in a hospital, multiple fracture, cranial surgery, all orthopedic people involved, neuro involved, everyone was involved. Patient remained almost for 2 months in that hospital and ultimately went to multi-organ failure, septicemia, severe septicemia. Yeah. At that stage, my team of doctors thought, why not give a best shot to give the life to the patient? So they have prescribed vancomycin injection without thinking of overdose, 2 grams 3 times a day for 7 days. Patient died because of the disease. But the relative of this particular patient was an orthopedic surgeon, has gone through all the medical record and found that vancomycin maximum dose as per the law is 2 grams a day. And he found that 6 grams a day has been given to his brother for 7 days. And he found the literature showing that overdose of vancomycin causes nephrotoxicity and neurotoxicity, and presented to court while filing a 1 crore compensation. Being a doctor, he left as a doctor for criminal case, otherwise criminal case would have been applied. He just gone to the consumer forum for 1 crore compensation and only one argument that this is what law says, that 2 grams a day, and this is what is given. And then overdose literature, 2 organs got failed because of that. Easy to prove a negligence. So what need not right is known to the people, what need not to be documented. So medical record, first defense. Second defense, consent and all, very well known to all the people. So I'm not emphasizing that. Second defense, I will re-emphasize, have a customized indemnity policy. As I said, doctorsays.com, you will find that
Certainly, I
Srikanth is
have
already a
compared
part
your
of that.
document policies, sir, with the other top Indian policies, and they don't even cover 70% of what you cover. I tell from my own personal experience.
See,
Because you're a doctor and you are also a lawyer, so you're thinking from both angles. The insurer is thinking about how to save money for himself. So that's been the issue.
Because I found in one case where patient fallen in a hospital and got a fracture, old patient, and liability came on a doctor. I've got a case where violence happened in a hospital and the people have vandalized the relatives and their car in a compound of that hospital. Liability naturally is going to come to hospital. We made insurance company to understand that, and the first time in a country we introduced in the same policy BPID coverage of 20% of premium amount. Means suppose you got a 1 crore policy, 20 lakhs of such a loss because of violence, if third party get, or because someone slips in your hospital and got injury, that is also covered. So we have thought of every possible thing to make a policy only with the interest that my doctor should get a test, and that is available. So I'll again tell you, you have a good professional policy. Yes, doctors.com, you can go on a website, you'll find that. Error omission policy is a mandate to all hospital owners. If you are owning a hospital, my humble request that please go for the hospital indemnity policy, which covers your all qualified and unqualified staff, all visiting consultant, all paramedical, RMOs, and directors, CFOs, CAOs, everyone, qualified, unqualified, everyone. And because of the latest multiple judgment in the country, 90% liability has gone to the hospital because it is presented to the court that cranial surgeon gets only 20,000 out of 4 lakhs rupees paid by the patient in a corporate hospital. The ratio of earning has been shown to the court, and court has given a judgment where 10 lakh need to pay by this guy and remaining 6 crore by the hospital. So now that has become a precedent. So hospital is going to have a huge responsibility to have a professional indemnity policy individual, have a hospital policy, error policy, which is again is a very beautiful policy available at doctor.com. Third, have a medical legal expert in a fingertip, means in our mobile. And at any given time, you can call them and take a help because they are expert in that field. Like you are expert in orthopedic, they are expert in their field. So there, don't hesitate to call them and take a help when need comes. I have heard
Kindly ask us, they have to share with me, sir, that document how to give the correct invoice by doctors. So that I can share with the delegates. And what I'll do is I will share Sneha's number with the delegates. They can contact to get that 1.5 page document. What is the ideal? Rather than knowing what we should not do with pharma, we just need 1 or 2 page what we should do with pharma. Because we have to develop, we have to innovate.
No,
so then
no.
For
purpose of our delegates, I'm definitely going to be. There's no question that because I really wanted the doctor should be litigation free. See, reason behind that. Any public document, suppose any case get filed against any of my colleagues, it become a public document. And once it become a public document, it can be posted on social media. There's no defamation on that because it is a public document. And if at all someone go on internet, put Dr. Arun, the criminal case will come or civil case will come. And today whole practices depend on review. So no doctor wanted to have a litigation against them. And to avoid such a thing, we definitely educate a doctor because this is the platform where they will get a lots of knowledge and they can avoid the litigation against them. So I have a medical legal expert on a fingertip. Yes, my numbers are there with Srikanth and Neeraj, and you all can have my number if at all delegates wanted to write. I will tell for their benefit. Srikanth, it is 9323446163, and Srikanth can share on a WhatsApp 9323446163. Why I am saying that? At least don't hesitate to take help of any medical legal expert. Fourth, educate yourself in medical law. Today, because of Srikanth and because of Ortho TV and many of the people who have organized this function, and thank to them because they have thought of their colleagues to educate them. Education is going to save you a lot. So try to upgrade your knowledge in a medical law. Various things are there. Go on internet, you will find lots of videos of other people, might be mine also, lots of articles on that. And I definitely recommend, Srikanth, you have done the course in medical legal consultant run by Global Institute of Medical Society gives. People, if are interested, even Neeraj, go and do such a courses of medical legal consultancy to upgrade your knowledge because that is the only savior to you. And fifth, naturally good training to your paramedical staff. In distant past, whatever cases I have got, it is majorly because of the attitude and behavior of paramedical staff. So my humble request that start training them. I mean, before I close my talk, let me give the final live example to you. It was a case of Mumbai where angioplasty done by my cardiologist doctor, after complete explanation of the risk to the patient, because patient was already in MI, all the 7 sons of this Muslim fellow has heard doctor prior to the procedure and knows the criticality. During the angioplasty, patient died. These people have happily accepted that because they were already consulted. Everything was fine. They were very happy with the treatment of doctor, all the attendants and the done by other people. But what happened in that case? They wanted to take a body. They went to the account department to have a clearance where they paid a 1 lakh rupees deposit. The live case of Mumbai itself, and bill was of 86,000. They said 14,000, keep with you. We will take later. Just give us a clearance so that we can take a body, because now it's everything is gone and people are now coming to the hospital. Accountant may be trained like that or maybe bound by the rules and regulation. Very strictly said, politely, and they have strictly said, keep 4,000 bill of pathology still remain. Go to pathology of same hospital, bring a clearance from there, then I will give you clearance. They said, 14,000 is with you. Why don't you pay 4,000? We are not taking your money. You at least facilitate that and give us a clearance. And that argument happened because of the rude behavior of that accountant. 7 brothers and their friend circle. Within a minute, I vandalized the hospital. By the time doctor comes rushing down, everything was gone. So attitude and behavior of paramedical staff plays a vital role, and multiple litigation is going in the court of law because of that. So I have a training. With this, my friend, with a close of talk, I will conclude with a few important aspects. Pharma relation definitely is important, but be cautious because laws are changing. Income tax department is also amended, so be careful because laws are different. It's not a violation of one act, but it is going to be mixed up for you. Third, liability, never ever get worried because laws are there to protect you. So criminal liability or medical counsel liability or civil liability is not a very worrying point to my doctor if you got a good people in your hand. Yes, but the defense have a good medical record, have a professional indemnity policy from doctors.com, have a medical legal expert, train your paramedical staff, educate yourself, can save you a lot. So thank you all. Thanks to Srikanth sir. Thank to all the management people, and very special thank to Neeraj. I got a call. I was very happy to see him here, Ortho TV, and all delegates specifically who have waited for me because of technical glitch, and Srikanth has managed because I wish to join you at 8:30, but I could not able to. But yet we have done our job.
Thank you so much.
Any questions are there? I am always. So thank you very much to all my delegates. Any questions? I am open for
that. Thank you so much, sir, for your time. Any questions in the audience? Yeah. So I think there are no questions in the audience. I'm conscious that it's quite late. 10:30 already. I'll let you know, sir, because you got a busy practice tomorrow. And again, I thank on behalf of all the delegates here at Ortho TV for your valuable time and what you do for the medical community. It's just unbelievable. And hope this thing continues for very long, sir. Thank you so much.
Thank you. Thank you very much. Thanks to all.
Okay. Bye, sir.
Thank you.
So I think we're just coming to the last part of it now. So
with all permission, I will leave.
Thank you, sir. Thank you. So just a few of felicitation here. I think this is online felicitation for Dr. Arun Mishra, certificate of appreciation from SSOC Bangalore. Thanks for his invaluable time, contribution, guidance to the medical community of the whole of India. So thank you, sir. Thank you.
Thank you. Thank you. Thank you very much. Thank you.
I think I'll just briefly introduce my teacher, Professor Ramesh Krishna. I know it's quite late in the night, but he's an amazing person, and he's my teacher, he's my friend, he's a role model because of his passion for fitness and for passion for cricket. And he's on the doctors panel of the Karnataka State Cricket Association, both for IPL and for all the international matches in Bangalore. If you need tickets and you need his phone number, you know whom to contact really. So he's presently the head of department of trauma and orthopedics and medical superintendent of the Victoria Hospital, the largest government teaching institute of our state. He's awarded the honorary FRCS by the Royal College of Surgeons of Glasgow. He's in the selection panel member for the MCH Edghill University. He's an assessor for the Medical Council of India. He's inspected more than 50 medical colleges in India. He's the first KOA fellow to travel to the UK. He's a member of the Joint Replacement Committee, Government of Karnataka. I don't know anything about it. I would like to learn that from the professor. And he organized 2 BOSCons, both in Wonderland, Bali. And to be honest, it is one of the best conferences I ever attended anywhere in the world. It has been the best conference, really. So thank you, sir. And I request Professor Ramesh Krishna to say a few words to us. Just bring up your slides 1 second. Yeah, but just that it's gone to Ortho TV. Just go to Ortho TV and then connect you 1 second. Yeah. Over to you, sir.
Yeah, good evening to all of you. First of all, I would like to thank Dr. Srikanth for inviting me here today and also for giving me giving a good introduction about me. Thanks a lot. I'm sorry that it's already too late and I won't be taking much time. So he wanted me to talk about some topic of my choice. So I really didn't know what to talk. So then finally I decided about this topic, an insight into the healthcare facilities available in a government setup. So the main idea I picked up this was there is a notion by everyone, common people, and even our colleagues and doctors and others in everywhere that the facilities in a government hospital is not as good and not up to the mark for the patients to take treatment, as well as for the doctors to send patients to these hospitals. So I would like to, my main intention is to change this notion. And I would like to show you that what are the things we have done in the government hospital. And I will be talking because I am working in this prestigious institution, Bangalore Medical College. I'm the head of the Department of Orthopedics at BMC. And I'm working here since 1991. I've completed 30 years in this institution. And I'm also the medical superintendent for Victoria Hospital. So this is the administrative block of the Victoria Hospital. Well, my talk will be focused mainly on the Department of Orthopedics, even though I'm the MS and I control other departments as well. But since I'm an orthopedic surgeon, I will be talking briefly about orthopedics. And it's not a talk, it is just I'll show you the facilities available in our hospital. Well, as HOD of orthopedics, I have been having all these responsibilities, the academic, administrative, and organizational responsibilities more than a decade now. And I'm happy that I started these fellowship programs in Bangalore Medical College about 3 years back in all these 4: advanced orthopedic trauma, arthroplasty, and spine. And we are in the process of starting the sports medicine, MD sports medicine. This is supported by the Ministry of Sports, Government of India. So we had a presentation in New Delhi, and we were selected for this prestigious medicine department. And they already gave us, even before the department started, they gave us 4 crores of amount, which we have spent most of it for the improvement of the orthopedics department and affiliated sports medicine department. And I'll just show you some pictures. This is the outpatient department. This is the latest building. It's a Victoria Hospital building where we have the outpatient department. And these are the new registration counters in the hospital. And this is how it looks. This is a 7-storied building. So it's a new block, which we have all the earlier all the OPDs were scattered in different blocks. So now we have all the OPDs in one block. It's a 7-story building with 4 lifts, and all various facilities are provided here. And these are the consultation rooms for the professors, and we have separate consultation rooms for junior residents as well. So earlier we used to see the junior doctors, postgraduates sitting around a table and seeing patients. We have changed all that. So each and every single postgraduate student also sits in a chamber like this and sees patients. And these are the various imported tables that we use for examination. And this is the minor OT and the POP room. And this is a demonstration room in the outpatient department. So we have a small demonstration room where we take classes for the students. And coming to the wards, each one of our wards have now Fowler beds. So which all the old beds have been replaced, and we have now Fowler beds in each of these wards. It started with orthopedics, and now the entire hospital has all these Fowler beds. And orthopedics department has about 150 beds. The entire hospital has about 1,000 beds. So it's a 1,000-bedded hospital. And coming to the operation theater, we have this latest. All the facilities are available in the operation theater. We have 1 emergency OT, 2 elective OTs, and I'm happy to have started this specialty OT, which is a new thing we started about 6 months back, where we do this specialty OTs, the different unit which operates on this unit, not the elective OT, the unit, and we operate only on plasticoscopy and spine in this OT. So there's a continuous surgeries being done in this OT. And we have high-end operation theater tables, and we have about 3 CMs and the striker drill and all the latest facilities, latest instrumentation in the department. And this was one of my dreams. I am a consultant at Manipal Hospital, Jayanagar, and other hospitals as well. So I used to see this doctor's lounge in all these private hospitals. So it was my dream to get this doctor's lounge in a government hospital, and I did whatever I could to get this. And we have this a very comfortable, spacious doctor's lounge for all the doctors to relax during in between surgeries. And this is the old OPD block, which now houses the orthopedics department. So earlier it was the OPD of all the departments. Now other than the OPD or the wards and the OT, the entire department of orthopedics is in this block, and we have the central hall of this building. And this is the new PG seminar hall which we have made. This block, if I think Shrikant remembers, this was the OPD earlier. So we've removed all the partitions, and we have made a beautiful seminar hall, air-conditioned seminar hall with all the latest audiovisual technology. And this is another small seminar hall for taking undergraduate class in the same block. And this is the department museum. So as per NMC, we have to have a department museum. So we have all the various charts and for the students. And we also use this as a meeting hall, a small meeting hall for department meetings. And this is the follow-up OPD there. And this is the physiotherapy and the sports medicine department, where we have, as I said, the amount that we got from the sports medicine ministry, we used it for getting all these equipments. And this is the orthotics department, and this is the artificial limb center. This is outsourced to this Jaipur Foot. So they are running this department, and they give free of cost artificial limbs to all the patients in coming to the hospital. These are some of the other facilities available in Victoria Hospital, and I am as a medical superintendent of Victoria Hospital since 3 years now, and I coordinate with all the departments, and I'm always into upgradation of various infrastructure and updating all the equipments and managing the manpower. These are the direction boards we put up everywhere. So earlier our patients and our colleagues had difficulty in finding which block is where. So this direction boards has been put up in many of the places in the hospital for them to locate where, because there are a number of other than Victoria, there are various other hospitals in the campus. This is the latest trauma and emergency care specialty of the casualty, which has all the latest facilities. This is the ICU and ICU monitoring system on the mobile, as well as this TV set is in the medical superintendent's office, which sets off alarms in case any problems with the patients. And this is a meeting hall for us to have small meetings within the department. And this is another dream which I had. I wanted to have a doctor's lounge in the OPD block where doctors relax and in between OPDs and during lunch they can sit and have lunch and coffee breaks and all that. So this is the doctor's lounge in the 6th floor of the new OPD building. And this is the auditorium. We didn't have an auditorium in the hospital, so we got a separate auditorium for the hospital. And this is the latest storeroom, all the newest types of racks we've got to store the medicines. And the smart city project, thanks to the smart city project, government of Karnataka, they have relayed our the roads, the drains, everything they've done, and it's a very beautiful place to move around. This is the garden, the hospital where we all have all our functions, whether it's Independence Day or all the flag hoisting and everything that we do in this garden. And again, this huge, I hope Srikanth remembers the Sirur block of this Victoria Hospital was a very old building. We demolished that building, and parking was a major problem in the hospital. So we use that entire area for parking, and I have earmarked a separate area for doctors and staff parking. So others cannot park in this area. And we have a separate help desk. And this was the ICICI Foundation gave us a high-tech ambulance, and this is about the UV sanitization chamber and oxygen optimizing unit, and all this was used during COVID. And we have done more than 1 lakh vaccinations in the hospital. And these are the isolation wards which we used, and also some wards we have kept till now for COVID patients. And coming to administration and staff coordination and monitoring, we are using this latest technology in the mobile phones. I regularly have meetings with the head of the departments, and we have staff meetings and review meetings, etc., and regular rounds with all the faculty and the staff. And we use this WhatsApp. So we have made lots of WhatsApp groups, and for whether it's admins or whether it's nursing officers, whether it's security, home guards, and group D's, drugs and materials. So all these are monitored, and all of us all the admins are there in this group, and we constantly monitor what's happening. And every time somebody does something, they have to put it up in this group, and anything goes wrong, we question them there itself, and immediately it is sorted out. And this is a group where all the heads of the departments are there, and the HODs, they have any shortage of drugs or any materials, they immediately put in this group. So it's emergency drugs. So we are there in the group, and the pharmacies, the main people involved in the pharmacy, the stores in charge, they are also there, and they immediately arrange for these drugs. And ICU bed status. Again, every time we used to have a problem whether beds are available or not. So we have used this WhatsApp group where every day it is updated. We know how many beds are there in the hospital. And the other regular usual problem in any government hospital is managing VIP patients. So this was another idea which I did, and we put all the ministers and other important people's PROs and our hospital PROs in this group, and the communication happens in this group only. So I am quite free. I don't have to take calls, receive calls, tell which patient has to go where. So it happens all electronically. And apart from that, we do celebrate, as I said, our Independence Day or Rajotsava, all these festivals we do celebrate. And this is the lighting of the administrative block in Victoria Hospital. And for this, the media had publicized this, saying that after 121 years, there was some Victoria Hospital lighting was done. And recognition and awards for whatever we have done in these past years, the Ayushman Bharat, this Kayakalpa Award, for COVID management, vaccination, and News 18. So we won all these awards in the last 5 years. And first of all, I would like to thank our own minister, Dr. K. Sudhakar, for his support. And these are some of the awards: the ABRK free treatment for trauma, arthroplasty, scopy, and spine. We have been doing all this free of cost for all patients. And this is for the COVID recognition for COVID management, and recognition for again COVID management. This is by them. Recognition for vaccination. Coming to the future, well, before that, I think Srikanth was asking me what this ABRK and Joint Replacement Committee. So I'm the chairman of Joint Replacement Committee, and there are two others in the orthopedic surgeons all over the state. Private hospitals and government hospital, they have to put up these cases. If they want to do a joint replacement, hip or knee or whatever, they have to put it up. They have to upload the case, the details to the SAST, the ABRK, and including the patient details, the X-rays and everything. And we sit there and we decide whether the patient needs arthroplasty or not. So we either approve it or reject them. So only if we approve it, so then the hospital, the government or private, can do it, and it's totally free of cost for the BPL patients. Coming to the future, so other things that I'm planning for the hospital is complete digitalization of the hospital. I'm having electronic office, entire management, e-hospital, modular OTs, and modular nursing stations. So finally, to conclude, so Victoria Hospital, or which is a state-of-the-art government hospital, is on par with, or some maybe better than, many of the private or corporate hospitals, whether it's expertise in the management of patients, infrastructure, equipment, and services. Thank you so much.
Thank you, sir. So I think it's time for felicitation, and I'm very happy and proud to say that sir has made our hospital, Victoria Hospital, government hospital, into better than many of the corporate hospitals I work in Bangalore. It's amazing to see those pictures. I've not seen for many years, but it's incredible work. And also the great leadership you have shown, creating WhatsApp group, monitoring, and putting all the even cases and approving whether somebody needs a joint replacement or not. Amazing initiative, sir, and very proud, and with all the work you're doing, and may this continue. Thank you very much for coming, sir. May I now request Mr. Shashi to come and sit here, please. I request Professor Ramesh. Yes. I request Professor Ramesh Krishna to come and participate. Shashi, please come sit here. Shashi in Karnataka fashion. Some pictures. Just trying to do that, Shashi. So may I request my friend Mr. Zulfi Kader and Dr. Ramesh, please. I request my friend Dr. Zulfi Kader to kindly come here. Facilitate Professor Ramesh Krishna. Sorry, sir, we made a long time. Take one picture. I think there's a sampling of sampling. So the green trend, which will just keyboard up, green as for you. So, please sit up. Request Mr. Zulfi not to sit. Zulfi is the chairman of the NAISH, and he's an amazing human being, and he's been doing a fantastic work in the field, of speech and language hearing. And over the last 2 decades, he has helped many children with cochlear implants and stuff. And his service to humanity in Bangalore, Karnataka is fantastic. Just take some pictures for this. Just conclude that. Just So just one last slide, just to finish off here. So thank my team who've been working very hard, the media team. So, there has been a technical challenge. So so just a vote of thanks. I take this opportunity to thank all the distinguished faculty for educating us, Dr. Ashok Sham from Ortho TV, Dr. Neeraj Bijlan, who has been very instrumental today, and Rishi for his help for broadcasting it throughout India. And I thank my friend, Mr. David Penford, for his help with the UK. And I thank all the guests of honor for coming here, Professor Ramesh Krishna and Mr. Zulfikadar, and all the delegates, both online and offline. So thank you so much. And we say sign off. Good night to all of you. Bye-bye. Till next time.